gadgets or switch it off. Otherwise, this will be happen repeatedly. So good evening, all of you, all the faculties, all the fellow trainees who are going to appear for exam or continuing the training program. Welcome to this Noel program. And this is today's session. It's not about a single case bedside discussion or presentation. This is about a mock examination where 3 cases will be examined as per the sequence, the way the care happens in the NICU. The first case will be presented by Dr. Shabya. She will present a ventilated baby case. And second case by Dr. Shailusa. She will present a CPAP case. And third case is a feeding, growing, stable baby in the NICU. So these 3 cases will be presented today. And they have joined actually faculties, 6 faculties, eminent faculties across the country. They have joined today to guide throughout the session and what expected in examination, how the question answer session happens to the student, when assessment happens for the student, and what is expected. So these 3 cases, Dr. Shabya's case will be examined by eminent neonatologist Dr. Naveen Jain sir and Dr. Naveen Bajaj sir. They've already joined with us. And Dr. Soilusa's case will be assessed by Dr. Srinivas Murki sir and Dr. Tejo Pratap. And Dr. Monisa Sawat, her case presentation will be assessed by today's session Dr. Rishikesh Thakre and Dr. Arjit Mahapatra. So they all two examiner will join when the student presents. But before starting the session, I will request the chief, the examination, how I will name it, I don't know, the examination section of NNF, the in charge this year is Dr. Naveen Jain sir. So I will request him to just briefly to introduce what is expectation of the assessment. Then we will go for the live presentation from Dr. Shabya. Thank you, sir. Thank you, both of you joined, so we can start after your introduction, sir.
Yeah, for the benefit of students, I will share only one slide that we showed in the last presentation again. So that might be of help. Let me see, it is here. Yeah. Nalini, is it clear?
Yes, sir. Perfectly fine.
Yeah. So your intensive care case or a sick baby who may be on respiratory support or other organ supports. It could be peritoneal dialysis. It could be on a central catheter and nutrition. Such baby would be given to you as a baby with maximum marks of 70. Your total examination time would be 30. Timekeepers would ensure that you don't get cross-examined for more than a few minutes more than that. 10 minutes would be there when you're standing near the baby and an internal resident gives you both written and you can talk to him where they will brief you about what happened to the baby before this. Then you have 20 minutes examination, cross-examination by 2 examiners. It is not expected from you to directly interact with the family, but like Dr. Naveen Bajaj said, if a mother or another family member is around, specific questions can be asked to them. We expect these areas to be deciding your marking scheme. In 20 minutes, please list for all the students. There is an ACON guideline you can find on the net, which is very helpful. ACON is acute care of atrius pneumonitis by the Canadians. It's just a template. It is not that you must go by that. Don't get nervous that you didn't hear ACON before this. But it just says that in 1 minute you do a primary survey and see is there primarily a respiratory problem, a cardiovascular problem, a neurology problem, is there a need for antibiotic, the fluid assessment, and so on, glucose and thermal issues. So you break up your assessment in these areas. Don't give only poetic descriptions of the baby lying on the middle of the bed and a pulse oximeter attached and all that. Please describe what you're seeing in relevance of this. Evaluate the severity of each of these illness and adequacy of the supports being provided. So maximum marks are for this. What are the problems you have listed? You may use a paper to list the problems so that you cannot forget them. And how severe is the problem? Is the baby supported adequately? Make a care plan for that day or for next few hours. What test you may plan? You want a blood gas, an X-ray, a culture, a blood count, a CRP, whatever. And what therapeutics you would continue, escalate, de-escalate, and so on. Some marks would be there for anticipating emergencies in a sick baby. And then theoretical content like a Viva starts where There would be discussion on what diseases were listed by you, what tests and treatments may be there on this baby. Lastly, we would spend a few minutes asking you to brief either the nursing team or the family on what illnesses this baby has and what is the care plan. I would ask Naveen Bajaj and Nalini also to brief before you go to the case presentation.
And generally, Naveen has said almost everything. I think with assessment of sickness, there can be adequate sort of relevant history, and assessment of sickness can be clubbed in this, and you can highlight that this is a relevant history which you need for this particular baby. And if you have asked it before, or if you want that information is relevant to that baby. Even if it is not provided to you, that is okay. Well, you should know that this information is relevant for this particular, for cardiac baby, this information, or for a respiratory baby.
So I agree fully. To just shortly one message, same thing. I will again highlight. If you know the disease process identified, as Naveen both sir told, that to highlight disease process system involvement, you know the most pertinent history which is responsible for this morbidities or this pathology, or the natural course of the disease which can change. So these two relevant, if we positive history we want to ask, we can ask and get before the presentation also. You can take the help. This specific history, not many negative history, 2 or 3 positive history which can change the natural course or which is responsible for the disease. That's probably way to identify more and more should be focused on the examination time or presentation time. That's my message to you. So with sir, can we proceed, sir? Both taking both of your permissions, I'm asking, can we proceed with the presentation request?
Yes, please.
Yes, Nalini, go ahead.
So this is Dr. Sabia's ventilated case. So I am briefing the detail 3 or 4 opening lines I am giving to her. So she will start presenting. Then after that, both the examiner will interacting with you. And in first 30 minutes, we will expect that this is a presentation, ongoing question answer. Last 5 to 7 minutes, closing session, both the examiner will give feedback to the student, which will not learning for the student herself, but completely the student mass who are attending today, for everybody will be learning. This feedback 7 minutes or 6 minutes. So with that, I am starting the session. The baby of a B, a 39 weeks, 2.5 kilo birth weight baby who born by normal delivery, now 23 days old, presented with loose stool for 5 days and respiratory distress since 2 days. Admitted in the hospital 24 hours before and intubated in emergency room. Now currently you are seeing the baby. So with relevant history and the examination, please you can go out with the presentation, Dr. Shah.
Good evening, sir.
Yeah.
So I'm starting with the presentation. So my baby of X came with is a 39 weeks born at 39 weeks of gestation with a birth weight of 2.5 kgs. Came with complaints of presented with complaints of loose stools in 5 days and respiratory distress since last 2 days, and was brought to the emergency, and where the baby was immediately intubated in view of the respiratory distress. So my baby, so currently this baby is on ventilator and receiving the following ventilator care, and I'm going to describe the baby is being nursed under radiant warmer, and the set temperature is 36. Set temperature is 36.5 degrees centigrade, and the measured is 36.4 degrees centigrade, and the heater output is around 25%. So there are 6 infusions, almost 5 infusions that are going on, which has IV dextrose with half normal saline, and 2 heparin with NS solutions, and 1 inotrope, that is dobutamine, at 6 micrograms per kg per minute. And yes, these are the infusions that were going on. Then baby is lying supine under the warmer, and baby has ET tube fixed at 8 centimeters, and it is secured well with no soakage. There's an NG tube fixed at 20 centimeters, and there is a central line placed on the left upper limb, which is a PICC line. And then there are two peripheral lines. One is a peripheral arterial line on the right radial, and there's a peripheral IV line in the left lower limb. So there's a pulse oximeter probe placed on the left lower limb, left foot, and temperature probe on the right upper abdomen. And there are ECG leads placed on the chest, and there is a urinary catheter, that's an NG tube placed in place. And coming to the ventilator part, baby is currently ventilated in SIMV plus pressure support mode with FiO2 of 30%, pressure total PC above plus PEEP, that is PIP of 16 and PEEP of 5 and rate of 30. And pressure support of 9. Pressure support of 9. Then there is a delivered tidal volume of around 28 ml, that is around 12 to 13 ml per kg, which is being variable now. Then there's a humidification chamber, which is reading temperature of 36.9 with adequate water level. And there is some amount of condensation in the expiratory limb. So now she's continuously monitored based on with a multipara monitor, heart rate, pulse ox, and saturations with an invasive blood pressure monitoring. So coming to the vitals, the heart rate is around is 114, slightly bradycardic, and the respiratory rate, as baby is on ventilator, on rates of 30, baby is breathing at spontaneously breathing at 46 per minute, and the perfusion of the baby, it looks the central perfusion of the baby. Overall, baby looks mild pallor is present. Peripheries are pale. Then blood pressure is recorded at 55 by 32, mean blood pressure being 42. And coming to the respiratory system, baby is on SIMV plus PSV, as I said, PIP of 16 and PEEP of 5, rates of 30, and I time of 0.4, and FiO2 of 30%. On this settings, baby is breathing pattern is well synchronized with ventilation, and there's a slightly high, this mild retraction present, and chest rise is adequate. And on auscultation, bilateral air entry is equal, and there are no added sounds. So on CNS examination, baby is lying in all four limbs are extended, mildly extended, and baby looks dull. Baby is currently not on any sedation, but off sedation, baby looks dull. The baby is on sedation. I'm going to check the passive tone. I'm not going to check the neck tone, but the lower limbs. So on stimulus, on mild stimulus, baby has a good cry. The sensorium seems to be good. on stimulus. There is withdrawal on passive flexion. Both the upper limbs have central lines in situ. And then neonatal reflexes as the baby is on ventilator. Currently, I'm not assessing the neonatal reflexes. So weight of the baby was 2.5 kgs at birth, and presently the baby's weight is 2 kgs. That is, there is a loss of 20% weight loss, and the at birth it is at 3rd to 10th centile. And AF is at level 1.5 to 1.5 centimeters. Bilateral pupils were reactive. No facial dysmorphism noted, and mild pallor present, and no other dysmorphic features. So summarizing, this is a term baby born at 39 weeks of gestation with a birth weight of 2.5 kgs and with admission weight of 2 kgs with a weight loss of 20%, and presented with loose stools and respiratory distress requiring intubation during admission, and currently on mechanical ventilation with SIMV plus PS mode on minimal settings, uh, uh, and minimum FiO2 requirements and pressure requirements. And on examination, baby is slightly pale, and there's mildly going on. So my diagnosis would be considering the respiratory distress during admission with loose stools. I would like to go with further history of feeding practices of the baby, and any top the whole feeding history, any formula feeds, how the formula feeds were given, and any if the baby was top fed, and I would like to go with any other family history of similar conditions, and the breastfeeding practices in the baby. I would like to know.
He has presented 10 minutes continuously. So any examiner in the meantime may not listen only constantly for 10 to 15 minutes. In the meantime, may ask some inputs, or it is just 10, 15 minutes we will listen and then only ask what is the pattern actually we're expecting in examination. Probably in between also, each system and examination is over. The examiner may ask to summarize and ask few questions also. That way we can still another 15 minutes there. We can probably go ahead with a few of the interaction, then can be summarizing the feedback. So both the examiner, I will request if anything you want to ask in the meantime.
Yeah, generally we try not to interrupt them in between, because sometimes they get confused with the question which they don't have in their mind. So that is the general pattern, that we tend to let them say what they want to say, and once most of their content is finished, and then we start asking a relevant history or a relevant any other examination or test they want to do. I think if we start initially 1-2 minutes only, then they fumbled up that what to tell to the examiner.
So Dr. Shabe, anything further to present, because you got 15 minutes. Before that, you completed your case presentation. So still yet to present something, to summarize?
Sarvaya, you are,
Assessment, something you want?
whatever information you want to gather, either from the history point of view or from the examination point of view, have you collected it and presented it, or you want anything else to do, any other examination you would like to do, or any other relevant history you would like to ask, or you want some any other information from history or examination you want to do?
History-wise, as the baby presented with loose stools and respiratory distress, mostly being acidotic breathing. So I would like to ask history regarding the feeding history, and the
That
baby.
is done. That
Yes,
is,
sir.
you have already told that you would like to ask the feeding history, whether it is a breastfeeding or a
Yes,
top
sir.
feeding.
Yes, sir.
Any other, you have said you want to ask family history of similar illness. What is in your mind, that what do you want to check in or rule out from the family history?
Any family history of diarrhea, acute diarrheal diseases in the family to rule out viral diarrheas, and any family history of sudden death or similar with similar illnesses and death due to the same or any other disorders in the siblings, or any consanguinity in the
What, so what does, if it is there, suppose the similar sort of history in the other sibling, elder sibling, or in the family, so what it points towards?
it can be a protein intolerance, lactose intolerance can be present, and then there can be inborn error of metabolism disorders can also be present, sir.
Hmm.
Dr. Shravya, you have taken history and clearly you described that there is diarrhea and weight loss.
Yes, sir.
So, what are your differentials to one or two or three differentials where a term baby would present with severe weight loss and diarrhea, and to the severity that baby would get intubated? So, what are the possible diagnosis going through your mind from the history alone? Only this much information is given to you. You are a consultant on the other side of the phone. A baby has come, he has diarrhea, weight loss, and we have to intubate him because he has some reason.
Uh, so if faulty feeding practices with
Dr.
parents
Shravya,
not.
they are the etiology.
Yes,
What are your diagnosis? What you're thinking? Why a baby would have diarrhea and weight loss to the extent that he gets intubated?
so there can be uh, viral diarrheas. There can be cow milk protein allergies. There can be inborn error of metabolism, which can present as severe dehydration and metabolic acidosis. And
What morbidities can cause you to have to intubate this baby?
so, due to the fluid loss from the body, there can be hypovolemic shock, leading to poor perfusion, which leads to metabolic acidosis and metabolic imbalance, hemodynamic imbalance, leading to which can lead to requirement of intubation, sir.
Any other cause? You're doing well now, because instead of going to diagnosis, it's cause milk protein. Intensive care is about stabilization first and then going to the second tier of diagnosis. So first you said that he could be a severely dehydrated baby with shock. What else can cause a baby with diarrhea to get intubated?
So there can be sepsis, which can present as
With meningitis, encephalitis?
sepsis.
Great. Third, fourth, which means
And
you have still not found what is in the examiner's mind. So one you said is shock, other one you said is meningitis, encephalitis. Then can electrolytes go wrong when you have severe diarrhea?
hypo, there can be hypernatremic dehydration,
Excellent.
and yes,
Leading to
uh, it can lead to increased viscosity of the blood, and there can be thrombus in the brain, which can lead to encephalopathy.
okay. Now, why we were driving you to this direction is when you do examination, you will be presenting, once you are in this history diagnosis method, you will be presenting to address whether there is uncorrected shock or methods have been used by the unit to improve the shock. Or is it that the baby looks like having meningitis encephalitis as a primary, which you will present during your examination findings? Or there are pointers to suggest electrolyte abnormalities and stroke or thrombus, whatever it may be. So, Nalini, you can take over.
So I won't ask any question here. I want see both the examiner has to take the examination for two examiners. For that reason, I'm just reserving my comments.
Naveen, you want to ask or she can
Sarvya,
present?
why there is a, what is the primary reason for respiratory distress in such babies?
So they can be, it can be due to multiple reasons. As there is fluid loss, it can lead to hypernatremic dehydration, which causes acidotic breathing, that is metabolic acidosis in the baby. That can severe metabolic acidosis can cause severe respiratory distress. And if this
So
is
is for metabolic, to confirm your this point, what investigation you will order
arterial blood gas, sir.
for metabolic, and what is the expected in that, in metabolic acidosis? What do you expect in that blood gas?
There'll be decrease in pH less than 7.35. If it is a severe metabolic acidosis, it will be less than 7.2. And bicarbonate levels, serum bicarbonate levels will be low, and base excess will be high.
And
And
what will happen? And what will happen to CO2?
CO2 will also decrease.
Okay, so what are other investigation you would like to do in such babies to support your diagnosis?
I would like to order for a complete blood picture.
You said 1 minute. You said the baby is dull, and then you again said that the baby is actively moving all the limbs. The baby looks normal. So, what are the to say that the baby is neurologically? So, what is the first point in examination in all neurological, either it is a newborn or a pediatric baby? What is the first point of a neurological examination you do? What do you assess when you neurologically assess a newborn, a sick newborn or a pediatric indoor baby? What is the first point you take or you would like to assess?
Sensorium of the baby, sir.
Level of consciousness.
Level of
So
consciousness.
how do you assess the level of consciousness in newborns?
We have
What are the different methods available, different examination methods available to assess the level of consciousness, different staging processes available?
there is Brazelton.
You can name any one of the most commonly used one.
There
That
is
is good.
Brazelton. Yes, sir. There is Brazelton staging, there is Prechtel staging, and there is Volpe's staging too, sir. So Brazelton is Brazelton or Prechtel is commonly used.
Okay, so what is this baby's consciousness level according to the staging you have done? Which staging you have done?
Brazelton staging, sir.
You know the components of that?
Yes, sir.
Hmm.
Baby can be in deep sleep or light sleep. Then there can be baby can be calm and alert, and baby can be highly alert. and baby is
In
white color.
your unit, which staging pattern do you use to assess the level of consciousness in newborns?
Brazelton, sir.
Okay. Okay, so coming to again to that what are the investigations you would like to do, and what do you expect in that?
Complete blood picture to look for the hemoglobin level as the baby is pale, and total counts to look for sepsis, ANC, and platelet counts. And we can also look for PCV. And then we look for septic markers, the other septic markers, CRP. Pertaining to hypernatremic dehydration, we can go for electrolytes, serum electrolytes, where we look for sodium, potassium levels, and we can also order for lactate levels as to rule out sepsis, and in inborn error as a part of inborn error of metabolism workup also. And we take a blood culture before starting any antibiotics or to go further.
I want to ask one quick question.
Yeah.
Both of you are- So quick question. So welcome Dinesh sir also here. Quick question, sir. One question to start with. You are dealing metabolic acidosis. You are telling acidosis repeatedly. We don't know the cause. Already Naveen Bajaj sir asked you what are the investigation you will do. So available investigation, ABG, electrolyte, everything with you now. Can you do something? Can you say, what is the cause of this metabolic acidosis from this information? The electrolytes information is available to you. Lactate level, ABG available. Then you are talking about ABG information, all the information available. How you will say this is which group of disease causing this metabolic acidosis? Can you calculate something where you will tell which group of disorder is responsible? I'm not taking exact data.
Anion gap we calculate in metabolic acidosis, sir. So non-anion gap metabolic acidosis and anion gap metabolic acidosis. So non-anionic gap metabolic acidosis causes are different. In acute diarrhea and renal bicarbonate losses, there will be renal tubular acidosis. There will be
One minute. It is a metabolic acidosis. One is normal anion gap, other one is low anion gap.
Yes, sir.
Right? Or it is increased anion gap. How do you calculate anion gap? I hope you know that.
Yes,
Yeah.
sir.
Yes, tell me.
1.5 into bicarbonate plus 8 plus or minus 2, sir.
Anion gaps survey.
Yes, sir.
I am asking how to calculate the anion gap in a people.
Yes, sir. Cations minus anion, sodium plus bicarbonate, sodium minus bicarbonate plus chloride, sir, together.
Okay. So what are the two commonly disorders in anion gap? One is normal anion gap. So what are the reasons for normal anion gap acidosis?
Yes, so generally in newborn, in acute diarrheal disease, acute diarrhea can cause non-anion gap metabolic acidosis, sir, and renal tubular acidosis and ileostomy. If it's a surgical baby, gastrointestinal losses generally causes non-anion gap metabolic acidosis, sir. If it's a premature baby, they can be
No, you can remove mask. I'm not able to. Yeah. You have said a normal anion gap, and the second one you said is
decreased anion gap metabolic acidosis.
Decreased anion gap metabolic acidosis. Okay. Any other investigation which you have missed, or probably I may have missed hearing that, which can lead to decrease in consciousness levels, metabolic acidosis, decreased feeding? Any basic investigation which we all do whenever any baby comes to an ICU? Did you mention blood sugar levels?
Yes, sir. Blood sugar levels. We do blood sugar level. I must do blood sugar levels, sir.
Now tell me, do hypoglycemia causes metabolic acidosis or metabolic alkalosis?
Sir, as a part of disease process, they too
Alone simple hypoglycemia. Let's leave aside this baby. Hypoglycemia alone in a baby can lead to which type of metabolic disorder? Metabolic change in blood gas. You can put it in other simpler. Hypoglycemia will cause, I'll give you two options, metabolic alkalosis, metabolic acidosis, respiratory acidosis, respiratory alkalosis. Which one you will choose?
Metabolic acidosis, sir. Hypoglycemia will lead to decreased tissue oxygenation.
That is okay. I am not asking. That is all theory you will do. If you suspect a metabolic disorder, which basic investigation, first initial investigation you will send on first prick of a baby? One is blood gas you have. What other basic investigation you will send when we approach any baby with metabolic disorder?
We do blood glucose, blood ABG, then lactate should be done, sir. Then ketone should be checked. Then ammonia. Any metabolic disorders, first we check ammonia, sir. Then we approach the metabolic disorders.
Okay, Naveen?
The working problem at admission was severe dehydration, I believe, with 500 grams weight loss.
Yes, sir.
You see this baby in an ICU where ER team has shifted the baby. You have intubated the baby for poor respiratory efforts. Is this baby at your time of assessment corrected in his dehydration status? Clinical assessment. Is his dehydration corrected or undercorrected or overcorrected?
Yes, sir. To see the status hemodynamically, first, the heart rate is well maintained, sir. There's no bradycardia or tachycardia. Blood pressures, the mean blood pressure is 42. That is acceptable for this baby. Saturations are well maintained. So this is the hemodynamic status, and dehydration.
I want you to get more marks in hemodynamic assessment, and only two I'm taking. Saturation, I will keep it for another one. You told me about heart rate. In a lighter vein, most people are going to echo straight, but we can spend some more time on clinical assessment of hydration. You said one was heart rate, blood
perfusion,
pressure.
sir.
How do you assess perfusion?
So, CRT, capillary refill time, we check for it. If it
How
is
much
less
is
than
it?
3 seconds, it is 2 seconds, sir, right now.
Okay.
And how are the peripheries, whether that dusky increased peripheral capillary refill time can be checked.
Describe also. So all students, when you describe vitals, you interpret them also. Suppose you say this is the heart rate, they interpret whether it is okay or it is insufficient or whatever. So what is his core peripheral temperature difference?
Sorry, sir.
What is the core peripheral temperature difference on this baby?
So both center and periphery seems warm, sir. These peripheries are warm.
So you describe to us capillary refill time, peripheries, heart rate, blood pressure. What are the organ failures that may happen in a baby who has been hypovolemic, severe enough to get intubated?
Hypovolemia, it can affect the heart, where the cardiac output will be low, the preload will be low, and then first the affected organs are renal perfusion will be low, so there can be AKI, and then there can be decreased urine output, and there can be hepatic dysfunction, decreased blood flow, they can which can lead to coagulation abnormalities, and later there can be VQ mismatch because of the decreased blood supply in the respiratory. Then finally,
let me help you, Shravya. You said renal dysfunction, and I'll add gut motility also in that.
yes.
Is there any active measure that you can see on the baby for monitoring the renal function? Are they actively monitoring urine output on this baby? Do you know this
Yes.
information, or it's only the charts?
Yes, sir. Urine output is continuously monitored in this baby. So there's a catheter in situ through which urine output is being monitored.
Okay. So you see some urine inside the catheter
Yes, sir.
or in the collection unit?
Yes, sir. In the
Would you
car.
like to describe that in relevance to adequacy of correction?
Currently, it is pale yellow colored urine, sir. So if it is dehydration, if severely dehydrated, it can be concentrated dark colored urine.
All right. Very good. What about the abdomen?
So abdomen, there can be generally in newborn skin turgor is not checked, but skin turgor, if it is more than 2 seconds, it is a sign of dehydration.
You're talking skin turgor or capillary refill time?
Skin turgor, sir.
So you said one of the complications this baby can have is hypernatremia. So would you please focus the camera on the baby and show your colleague students how you will look for hypernatremia clinical sign demonstration? All right, if they're doing care for the baby, you may not disturb the baby, but these are some of the questions. Obviously, you're not going to get a baby of dehydration and diarrhea in your examination. It could be another baby. So you could get from two different examiners, two different perspectives, how the case can proceed. You can either get, like Naveen said, a clear description of potential etiologies, and questions can branch out from there. Or you could get them to ask you to interpret the vital signs to assess how seriously ill the baby is and how well he is supported or not. So I go back to Naveen Bajaj to ask few more questions. I think we have few 5-6 minutes before we close our case.
Okay, so have you reached to a more specific diagnosis in this baby from all we have discussed?
So I would like to have some more history, and we would like to have investigations plus history to reach a particular diagnosis, sir.
Okay, tell me, is there anything like a congenital diarrhea?
Congenital diarrhea. Any malabsorption syndromes or any gut congenital malformation leading to diarrhea?
Okay,
Okay,
like we were
what are
discussing.
the other possibility? Okay,
No, sorry.
so what is the other possibility? You can think of a baby who is having failure to thrive and came at around 23 days of life, 3 weeks with shock, failure to thrive, weight loss. Any other possibility or any other examination you would like to do? You would like to see anything to rule in or rule out that possibility?
Um,
So a 3 weeks old term baby comes with shock without diarrhea. Let's say there is no diarrhea. A 3 weeks old baby comes, a term baby comes with a shock. Which other disease, which till now you have not thought could be there?
there can be a congenital heart disease leading to shock, sir.
Which disease, congenital heart disease, can present with shock at 3 weeks of life? Which specific disease?
So duct that it's a term baby, so they can be a PDA which do not close, or
Okay, so you are not there. I want to be, let's not go to that. So PDS will present in first 72 3 days of life. It will not present at 3 weeks. Okay, which other disease a term baby can present with shock at 3 weeks of life? With failure to thrive and shock.
The clues are the sodium may be in the other direction.
Your electrolytes will give you a clue. Naveen has already said. Your electrolytes will give you a clue. Okay, so now what you will like to tell the family now, that how this baby's condition is and what are your further plan, and what is the prognosis. They will ask. The first thing they will ask whether my baby is normal or not normal now after say 24 hours are there. The second thing they will ask whether this baby will survive or not survive, or what sort of this they will ask which disease this baby is having. We might not be knowing it completely at 24 hours, but they will ask. So how you will counsel them and satisfy them that yes, what is going on in the unit, we are going in right direction.
so once we stabilize the baby, uh, uh, we so we look in what direction the baby is going on. If the with the given corrections and with the
See, suppose
consistent.
I am the relative, whichever relative you can think of, I am the relative of the baby. What you will tell me, that what are the points you will, I am asking you, how is the condition of the baby and what is the prognosis of this baby?
So as the um, so uh, currently we have put the baby on ventilator, as the baby was requiring ventilator. So after putting the baby on ventilator, the baby's heart rate and heart rate seems to be settled down, and the loose stools which were happening, which has led to.
No, that is the etiology. They also know and you have already described. I am asking, is my baby normal? Doctor, is my baby normal? Will my baby survive?
So currently,
That is the direct question. You must have confronted it before also in your unit.
yes, sir. So currently the baby is on ventilator, which means the condition of the baby is critical, as baby is on the ventilator. But on the ventilator now, baby is making progress. So we need to rule out the cause of this condition. So after which, most of the times it can be due to the causes which are correctable. So once we correct those causes, the baby's status will improve. But there are in a few conditions where this is a chronic condition. So we need further evaluation if this does not settle down in the coming 1 or 2 days.
Doctor, will you give me guarantee that this baby will survive?
So as the baby is on ventilator, we can never guarantee that the baby will survive. But as we monitor the progress of the baby, we can we will be able to tell you the further prognosis of the baby.
Nalini, you can tell us where to stop
Just another
from
1 minute,
the
sir,
time.
only.
Yeah.
So a little late we started because of our introduction session, but another
Okay.
2 minutes we have to close actually. Sir. 8:30 we have to close this session to go to the next presentation. Sir. With the feedback quickly, both examiner, if some final feedbacks will give, that will be useful for everyone. The question answer session, but the feedbacks are actually 2 or 3 important observations from both of you, the presentation and answer, question answer, that will probably guide all the students who are listening. 2 or 3 important feedbacks.
Okay. I think, Naveen, we can give feedback now. I am asked if you want to ask anything from Survey. Do you want to ask anything else from Survey? Naveen?
Just one aspect, just for the benefit of other students, what emergencies are you going to prepare your nurses and your residents in taking care of this baby today?
So as the baby is on ventilator, baby has ET in situ. We need to tell them and train them regarding DOB phenomena, where any which can lead to emergency. Then there can be any, as it's a baby recovering from shock. The blood pressures need to be, hypotension and heart rate should be addressed, and any changes in the vitals need to be informed, and the other temperature control should be maintained well. The humidification and the surrounding temperature with the warmer should be maintained well, and the fluids, and as this large amount of fluid is going on, the IV line care should be taken care of, so that
Great, you've done very well, Shravya. So before I hand over back to Naveen Bajaj, you just saw that it is very difficult to prepare for a cricket match because the balls can come in different directions, different pitches, different bowlers. So if you love cricket, that is. But don't get unsettled. No examiner comes there to have you fail, but they can have a different expectation from you, and therefore don't be preset in idea and keep going. This is not for you, this is for everyone. And be alert in trying to see what the examiner may be asking. He may be wanting to elicit anion gap from you, or he may be wanting you to talk about high sodium or low sodium. So clearly, attentively listen to the question. If they ask what are the possible causes, then list the causes rather than again enumerating all the information that is there, because it gives you high marks and gives you opportunity to be asked more questions. That is all for me. So make sure that you are able to judge what the examiner is searching and asking you.
Survey, Naveen, I agree with you, and I'm not going to give you specific comment about this case, that what you have told or what you have not told, what is wrong, what is right. But in general, yes, spend some more time on examination. You know, look, inspection is the most important. Feel, do touch the baby, and hear. So what the baby is trying to say. So observe, palpate, touch, or auscultate. Three main components. Observation obviously is the most important, and it keeps on happening all the way while you are, even answering the question. You can still observe the baby, and if you have missed something, and examiners tend to ask you something else, like if it is a CEH, then the examination you could have immediately you can immediately see what the genitalia is looking like. The baby is already having catheter. So just keep yourself aware of the surroundings and keep your all senses opened up, and that's it.
Pravya, you want to ask something from the examiners for the benefit of your friends?
Abhay, you want to ask anything?
no, sir.
Generally,
Like,
students directs the examination which way to go, which way the question and answer sessions will go. It might be different from the what the disease, what the baby is suffering from. It might be completely different from, because it is not that particular baby, but the assessment is the overall over assessment of the overall subject assessment it is. You might have got a CPAP case of respiratory distress or a metabolic disorder or a CNS meningitis, but the assessment may not be pertinent to that specific case. It depends upon how you are answering the question. You can direct the examiner to the topic you know better. That is in your. Nalini, anything else you want to add? Sometimes this online things might be, actually seems different than what in the real world scenario happens when you are face to face with the examiner. It becomes much more quicker also.
I spoke before already during history time, but I will just see maybe briefly when Dinesh sir joined. Any inputs in general, sir, actually, not for this case. One before requesting you, I'll say, sir, to Shravya or all the students who joined, I will say when examining, you examine and say the way you highlight the history, relevant positive history, which responsible for the disease or changes the natural course. Like that, you are examining this case, as Naveen Bajaj sir told. You are examining the baby in the diaper, opening the diaper. If there's diaper rash, skin excoriation, diagnosis may be differently. If the hyperpigmentation around genitalia, diagnosis will be different. If you say general skin examination you are doing in electrolyte dyselectrolytemia with edema, with generalized edema or without edema, the diagnosis will be different. Highlight it. If you are talking about metabolic acidosis, you talk about your bicarb, you talk about sodium, talk about chloride, lead the examiner towards metabolic acidosis, normal anion or high anion gap. You're talking about a protein intolerance, lactose intolerance, anything diarrhea region. You say about I checked the particular the ABG time. If there is some clues there, if your ABG you are doing, you saw lactate high, highlight it. Methemoglobin high. Methemoglobins are the clues for specific some diseases. Highlight it. If a very hyperchloremia or hypochloremia, highlight it. So I'm saying history, clinical, physical examination, and investigation. We are speaking specific point to highlight. You will lead and shortly probably you will reach to your differential diagnosis. That's the way to present. Then vaguely present the facts only. Presenting the laboratory investigation, consolidated towards few of the diagnosis points will help you leading within 15 minutes to a diagnosis. That's probably my message. But I'll say Dinesh sir actually overall case presentation he was listening. Some words sir actually.
Hi, good evening, everyone. And Shravya, very well presented case, and thanks Naveen Bajaj and Naveen Jain. I just had a few comments about to all the students. See, this was a ventilated case, and we would probably get a different types of cases. This was child with unusual one, some child with respiratory acidosis who got ventilated. But you might have any other child with meconium aspiration, PPH, and different. What actually helps, I know, as I think Naveen has mentioned in his presentation, that going in a structured way, like a respiratory system, cardiac or hemodynamic assessment, and if anything positive on the clinical examination findings. And what helps you in directing the examiners is summing it up. So this is a sort of day 2 of admission of a child who came with a severe metabolic acidosis and was ventilated because of that. And currently, what is his suppose ventilation, because this case we probably didn't discuss much about ventilator, but many a times on a bedside, the examiners tend to probably talk to you a little bit more on the ventilator about how is the ventilation, what is the settings, why you chose this, is it adequate? Those type of things. Sometimes the discussion goes on that. And whether this is adequate, because this child, if he was ventilated for a child with acidosis, is he ready for extubation? Has he come for a minimal setting? Why is he still on a ventilator? Those type of discussions will still come on. And you can lead the examiner by actually sort of thinking, oh, I thought the cause of metabolic acidosis is probably, severe dehydration. And my current finding is that the dehydration is corrected. So I think many a time, your current examination findings, like at this stage, there is no signs of dehydration. At this stage, the end organ perfusion looks like that. This type of things will help you to control your discussion. Otherwise, what happens is the discussion can go in any direction. You can determine how your long case should go. and you should go dominantly on the respiratory side, you would like to go on the diagnosis side, you have to go on the etiological side. So trying to sum up the case at the end of your clinical examination and giving a brief about what you think will help you, the examiners to ask you questions. This is probably what I would say, but be systematic in your approach so that you don't miss out on things. And give only relevant information rather than giving all the information which may not be necessary. Thank you.
Thank you, sir. So thank you all the faculties who have already, Sir Naveen Jain sir, Naveen Bajaj sir, and Dinesh sir who given inputs. But all the other faculties who joined, I welcome all of them. Srinivas Murthy sir, Dr. Arjit Mahapatra, and Dr. Tejo, they all joined. So in the meantime, I will just inquire once Dr. Soilu sir, are you ready for presentation? Because we will move to the next case, which is a CPAP case, to be presented by Dr. Soilu sir from Fernandes, Stockholm. And for this, the examiner we have invited Dr. Srinivas Murthy sir and Dr. Tejo Pratap. They both, Dr. Tejo Pratap from Fernandes and Dr. Srinivas Murthy sir from Paramita Children's Hospital. He's a neonatologist, chief neonatologist there. Everybody knows in neonatals forum, no need to introduce it. But here, these two examiners will be probably cross-examining the student, Dr. Soilu sir. But other faculties, I will request if you can stay a few more minutes. In the meantime, brief 1 or 2 inputs if you can give. It's most welcome, all of you. So
you can have a
please,
session where
Soilu sir.
the faculty can question the faculty. Yeah.
Soilu sir, are you ready?
Yes, ready.
So if you are ready, I will request Dr. Tejo Pratap to opening line, actually opening case presentation, few lines to provide to the presenter so that she can start presenting. And in the meantime, we can provide, as from beginning of session, sir told, extra any information, relevant positive history or relevant history. If a presenter wants to know, probably somebody can provide to the event.
Well, luckily, I'm just inside the hospital only. I will go there and then give her the thing so that it will be like a live examination. That's what I was thinking.
No issues. You can speak from this presentation, go to there, or directly you can reach the presentation place also, not issue. From there you can.
Sailusha, this baby is baby of Jane and product of a twin pregnancy, which was a DCDA pregnancy, and baby delivered by emergency in the CS in view of severe preeclampsia in the mother and born at 29 weeks of gestation and 1 day with a birth weight of 950 grams. Baby cried after stimulations and Apgars were 7, 8 and 8 at 1, 5 and 10 minutes. And baby soon required bubble CPAP in view of respiratory distress and also received 1 dose of surfactant. Currently, baby is day 7 of life on respiratory support of bubble CPAP and also on tube feeds.
Good evening, sir. Sir, can I know the gravida of the mother?
You are able to hear?
Yeah, we're able to hear. Please go ahead.
Yeah, ask.
What is the present gravida event?
Gravida 7 with the 3 live births and 2 preterm deliveries and 1 abortion.
Previous preterm delivery.
Yes, there were 2 preterm deliveries, one at 29 weeks and one at 32 weeks.
Well, steroids are covered for the mother antenatal.
We don't know about the previous deliveries. For in this present delivery, there were 2 doses of steroid which were covered.
Prior to delivery, when was the dose of steroid?
So just 1 day prior to delivery, the steroid coverage was complete.
Whether delayed cord clamping was done in the delivery?
No, delayed cord clamping was not done.
Any cord milking or
No.
in the delivery corner, what was oxygen support you gave to them?
So baby required immediate respiratory support. So we gave, we started the baby on delivery room CPAP with FiO2 requirement of 30% initially.
When was the surfactant given?
So as the FiO2 requirement kept increasing, it went up till maximum FiO2 requirement was 60%. So we gave the surfactant within 20 minutes after birth.
Anything else you want to ask?
Did the mother receive magnesium sulfate?
Yes, before the delivery, loading dose was given of Maxine.
Okay. What is the first statement you want to make about any baby? How do you address a newborn baby? You are in the neonatal unit. You want to tell me about the baby. What is the first statement? You address this baby to me. You tell me what is the...
Image. Based on gestational age, I will address the baby. Term, term baby.
So you'll tell about the gestational age. What else?
Weight, sir, whether extreme low.
Birth weight. Can you tell this in this baby?
It was 950 grams, sir. Extreme low birth weight baby.
Okay. So first you need to tell the name of the baby. Address the name of the baby. What is the name of this baby?
Baby of Jebin twin 2. Baby of J, sir, twin 2.
Baby of J, twin 2, 29 weeker, weight?
Of 950 grams, sir.
950 grams. Girl or boy?
Male baby, sir.
Boy. How many days of life or how many hours of life?
7-day-old, sir.
7 days of life. So 7 days after birth. So always your opening statement should include babies. What is the name of the baby? Gestation, weight, and sex of the baby and age of the baby, preferably also AGA, LGA, SGA. So what is this baby?
Baby AG.
AGA, 29 weeker, 950 grams will be AGA.
Yes.
11th centile. So what is the thumb rule? Easy to remember. So yeah, 29 weeker, 900 grams is the lowest cutoff. 28 weeker, 800 grams. Okay, 30 weeker, around 1000. That will be the lowest cutoff. Okay, thumb rule. But you have to look at the charts and let us know. Okay. So now, do we know the reason for prematurity from the history? Do we know the reason for prematurity? This baby is born at 29 weeks. Whatever history they have told you, do you know the reason for?
One is pregnant. Mother is hypertensive, sir.
So does that tell me that that is a reason for delivery?
Previous preterm delivery history is also there.
So all pregnant women with hypertension and previous pregnancy deliver at preterm?
Okay.
So what was the indication for delivery here? Do you know from the history? Can you ask them what is the reason for delivery? What history you want to know the reason for delivery? You need to ask them. So they said it is PIH and previous preterm. So how will you elicit the history of the reason for delivery? When will we deliver a preterm baby with a mother with PIH? What will be the reasons?
Doppler changes could be there.
So, okay, Doppler. What type of Doppler changes they will deliver the mother?
Absent diastolic flow could be one.
Absent and?
Reversal of end-diastolic flow.
Okay. What else? What will be the other reasons apart from Dopplers?
PPROM.
So, yeah, PPRM can be a reason. What else can be the reason? You have PAH, Doppler abnormalities, PAH. What else will be the reason for delivery? Yeah, somebody is suggesting there. So if the mother had uncontrolled blood pressures, or if she has preeclampsia or imminent eclampsia, okay, those are the reasons for delivery from the maternal side. What else from the fetal side? You know this.
Fetal well-being, if any fetal distress.
So if there is a fetal distress, they'll be delivering. What else? Prolonged severe IUGR for more than 4 weeks, static growth, oligohydramnios. Okay, so can we find out from this mother what is the reason for delivery? Maternal or fetal indication? What will you ask them?
It's a maternal indication, what the Dopplers normal.
So it was a maternal indication. Mother presented with hypertension, which was uncontrollable in spite of giving medications.
See? Okay, so now what questions you want to ask? They are saying it is uncontrolled hypertension. Next, what should you ask? What do you mean by uncontrolled hypertension? What questions will tell you that this is uncontrolled hypertension?
Even with medication,
No. What history will tell you that this was uncontrolled hypertension?
so eminent signs of preeclampsia,
So can you ask her what signs you want to ask her?
any blurring of vision,
No.
headache,
No,
Blurring of vision, headache. What else?
left is liver function tests were normal.
yes,
Okay, what else? Headache, blurring of vision. Don't want to ask about seizures?
Mm.
You want to ask about edema?
Mm.
Okay, urine output. Okay, so then only you know that whether there was an imminent eclampsia or not. So now, if there was no imminent eclampsia, then uncontrolled blood pressure. So what medication the mother was in? Why that has a relevance? What medication mother is on?
Before, if max sulfate was given, it will help in neuroprotection. So
Okay, one, it can help in neuroprotection. What medications can harm the baby?
labetalol, these can cause hypoglycemias in babies.
Very good. Beta blockers can cause hypoglycemia. Should know that history. What else?
If she's on any ACE inhibitors, renal agencies could be there. So
Renal agenesis or something else. ACE inhibitors can shut down the fetal renal output. Okay, they can cause renal failure, difficulty. So it's a contraindication in pregnancy, correct? Okay. So we know the reason that mother had uncontrolled hypertension. You need to find out what is the blood pressures and what medications were used. Can you find out?
the mother is on what medication for
she was started on labetalol at 28 weeks of gestation when the blood control was on, blood pressure was on the higher side.
max sulfate was given.
Only the loading dose was given prior to delivery.
Good. So now this baby, we know why it is being delivered. Now there is an important history of previous 2 preterms at 29 weeks and 28 weeks, I think, correct? So what other history you should take for previous preterm births?
Whether cerclage was done or. no.
Okay.
Cerclage was in situ.
Okay, what else?
Mm.
So previous preterm, what is the medication they use?
Tocolytics will be used
Okay, tocolytics can be used for, why do they use tocolytics?
to prolong the pregnancy duration.
So what is the role of tocolytics in preterm? Does it prolong pregnancy or is it used for something else? Hmm? Tocolytis is used only to give the time for steroid coverage. Okay. Okay, so tocolytics were used, but my question was different. What was my question?
Because it
Previous 2 preterm births at 28, 29 weeks. You said cerclage was done or not. I asked, is that the primary medication for preterms? Previous preterm birth, what is the medication which obstetricians use?
ecosprin maybe.
Ecosprin is for pregnancy-induced hypertension, not for preterms. Previous preterm births, what is the medication? Yes, somebody has said it's progesterone. Okay, so hydroxyprogesterone is the drug of choice. So you need to know why. What else? This pregnancy also maybe because of that reason only. No. So what history will tell you that okay this, or what investigation finding will tell you that whether this mother had need for cerclage or not? What do you want to know?
Cervical length.
Okay, cervical length. So can you find out what was the cervical length before cerclage so that you can?
What's the cervical length? Cerclage.
It was 18.
So anything else apart from length? Very simple thing you can ask them. What do you call funneling? What do you mean by funneling? What do you mean by funneling? What is funneling?
Cervix will be.
So
And it,
internal os, opening of the internal os, forming like a funnel like that. Okay. Okay. So now we know the reason for prematurity in this baby. We also know probably the reasons for previous preterms, because there is a cervical stitch in situ, and that maybe there is some amount of cervical incompetence. Okay. She had 2 risk factors, major risk factors for baby to be born preterm. And you have some very relevant, important history which can affect the outcome of this baby. So what are the things which you have already asked?
The antenatal steroids were
So
covered
steroid coverage you asked for. What else?
when it was covered prior to delivery.
Very good. So
Mhm.
full course of steroids, but last dose before, how many hours it should have been covered for?
It should be covered within 24 hours, sir.
24 hours after the last dose, the delivery should happen. Okay, that's why we end up giving tocolytics to prolong it for at least 24 hours after the last dose. Okay, what else? So
Magnesium.
how steroids will help the baby?
Because this antenatal steroids, because it's a premature baby, it will prevent IVH, NEC, respiratory distress syndrome, mortality. So
Good. So mortality, RDS, severity of RDS, pneumothorax, IVH. Okay, most of the neonatal morbidities are prevent. Okay, what else? So you already asked those questions. Yeah. So steroids is one question. Second is Maxelf. Anything else? Will the place of delivery matter?
Delayed cord clamping was done or any cord milking was done.
So was cord milk indicated in this? Which baby's cord milking should not be done?
Less than 28 weeks cord milking should.
28 weeks. But here the baby did not cry. So they could have done cord milking or not?
They could have done, sir.
Okay, they could have done cord milking. But obviously it is not a compulsory thing because this baby is asphyxiated and baby came immediately and then they required resuscitation. So definitely for term babies we say, but preterm we try to avoid, especially less than 28 weeks, correct? Okay, so you spoke about steroid, you spoke of Maxelf, you know the indication, you know about that baby required resuscitation at birth. So when the baby comes to in the delivery room, what else you expected? If you were the pediatrician, what else precautions you will take in managing this baby in the delivery room?
Because this is a preterm baby, sir. First equipment check I'll be doing. Sir.
What special things you'll be worried about?
To prevent hypothermia, plastic wrap or occlusive wrap.
Very good. What else?
Oxygen blender should be there. Sir.
Yes.
And humidified air we need to provide, sir.
Why you need oxygen blender? If you want to start resuscitation for this baby, what oxygen you'll use? How much percentage of oxygen you use?
29 weeks.
Yeah.
21 to 30% we can start, sir.
So you need to give graded oxygen. So you need a blender, correct? What else you need?
And
So you said you need a blender. You told me that you need a cling wrap. What else you need? For this special baby, what else you need?
surfactant. We should be
Okay. The delivery room surfactant. What else?
appropriate size ET tube should be.
Okay, no. Tell me a specific for this baby. Will you use an ambu bag or something else?
TPs pieces.
What is the advantage of a TPs over an ambu bag or a self?
We can deliver control pressure cell so that pneumothorax and all can be.
How much PAP and PP will use in a baby like this? The baby requires a resuscitation.
PAP of 20 to 25 we can use. A PEP of 6 to 7 can be given.
Okay, so 5 to 6 is the PP will give for such babies. Okay, so delivery room CPAP, cling wrap, temperature maintenance, and blender. Okay, so these are the minimum things you'll need, especially for such babies. Okay, when the baby comes to the NICU.
Sir, just one more question. How many members you need in this team?
At least 3 members should be there.
So how do you decide about it? What is this pregnancy and how many you are requiring for your?
Because this is twin pregnancy, for each baby, at least 3 members should be there. So.
Any specification?
3 members, 6 people will be there for this baby. So 6 people will there in Neo hospital. 6 people were there at the time of delivery.
How many were there? At least
4 were there.
Okay, so in a high risk one baby, how many people are required?
2 people is enough. Sir.
And what is the characteristics of those 2 people?
This one should be trained in advanced NRP.
Very good. So one should be trained in advance and one should be able to initiate resuscitation. So 2 people at least for a high risk. And at what point you'll call for the third person? During resuscitation, at what point you'll call for the third person?
Failure to intubate.
2 people are enough, no? So when you'll call for the third person?
Chest compression.
Okay. So when you start the chest compression, you call for the third person. Okay. When you finish off the initial steps, you call for the first person. When you start doing the chest compression, you call for another person. Okay. Okay, good. So in the delivery room, we finished and then we are moving from, so some very important, what should be the delivery room temperature?
So it should be between 36.5 to 37.
Which labor room will have 36 degrees? What is the current recommendation of labor room temperature?
26.
Indian guidelines.
26 degrees.
26. 23 to 25. Okay. So 23 to 25, Indian NRP book is mentioning about 23 to 25 degrees Celsius. Okay. So we got the baby to the NICU. What parameters you'll assess in this baby at admission to the NICU?
First, we assess the temperature of the baby, sir.
Very good. How does it has relevance?
Hypothermia will further trigger all these things.
Very good. Very good. Very good. What else? So you'll monitor the temperature. So how do you measure the admission temperature? Warmer.
Auxiliary is ideal, sir. But
Admission should always be auxiliary temperature because warmer will take stabilization time, isn't it? Okay. How do you place a thermometer? Can you show me?
Sorry to interfere, sir.
Yeah.
9 o'clock we cross, sir. She has to present the case. She has to examine the case 10 minutes only.
Oh, okay.
Already we started presenting 8:41. Now we 9 o'clock, sir. So we have to ask her to present the case directly. Then further questions, both examiner Tejo and you can ask further questions and input, sir.
So you
she has
show
to
me how
present
to take the temperature and then you examine the child and then let us know the findings. Okay. Okay. Can you show us?
yes, sir.
Okay.
It should be kept parallel.
Okay, good. Okay, how long you keep it?
1 minute until.
So can you do this? Can you use this for measure the rectal temperature?
No, sir.
Why? Why can't we use this for rectal? Okay. Okay, understandable.
Describe the baby and then anything specifically you want to have in the history, and then you can go with the examination.
Okay, go ahead.
Go ahead with the examination.
Examine and let us tell the findings and then we'll ask you. We'll give you 1 minute. Yeah, please focus on the baby a little bit more.
Yes, sir.
You're done?
Then,
Yeah, describe the baby.
baby of J, presently nursed under radiant coma with temperature of 36.3 degrees with heater output of 50%, sir. Baby was connected to bubble CPAP with trans cannula being used as the interface. PEP of 5 and FiO2 of 21% and a flow of 5 liters per minute, sir. And baby is maintaining a respiratory rate of 44 per minute with a heart rate of 150 per minute, maintaining saturations 93 to 94% with the SA score of 1, sir. Vitals, CRT of less than 3 seconds. Respiratory system wise, sir. Babies on bubble CPAP with the following parameters: maintaining saturations and bubbling with adequate bubbling, and the baby was comfortable on CPAP and with humidifier temperature of 37 degrees and no water in the inspiratory limb. With intact skin adhesives on the nose, sir. And Voji tube was in situ, fixed at 18 centimeters, and head umbilical line was in situ, fixed at 7 centimeters, no surrounding erythema. Cannula was peripheral line was secured to right upper limb, sir, and pulse oximeter probe was connected to left lower limb. CVS, sorry, respiratory with a Silverman Anderson score of 1, sir. CVS wise S1, S2 hold, sir, no minus. And CNS tone was good, sir. And baby was sleeping.
Can you tell me the order of examination? Just the salient headings under which you'll be describing a baby like this.
First vitals, followed by head to toe, sir. Followed by respiratory, CVS, followed by systemic examination.
So in the vitals, first you have to describe the baby. You've done that. So you said so and so baby and under radiant format. So you didn't describe the baby completely. So first describe the baby. So what are the characteristic features of the baby? You look at the baby and then keep describing.
Head to toe examination.
Can we focus on the baby, please? Don't touch the baby, just keep describing the baby. Yeah. So this is the 29-weeker baby, 950 grams under a radiant warmer with a radiant temperature offset at how much temperature set?
36.5, sir.
36.5 and baby's temperature?
36.3.
Baby's temperature of 36.3 with heater output of?
50%.
With heater output of 50%. Baby is also connected, is nested, is under radiant former. There is a cling wrap attached onto the radiant former. Okay. Baby is also connected to a Ram's cannula CPAP. But what type of CPAP is this?
Bubble CPAP.
Using a ventilator.
No, sir. This is bubble.
Show me the interface. So this is you can set the PEEP and FiO2 in that.
Yes, sir.
FiO2 and flow you are able to set in that.
Yes, sir.
You can change the flows.
No, we can change.
Okay, we can't see it.
Okay, sir.
So it is you're able to change the flow and FiO2, correct? Okay. Okay. So you also told about the humidifier temperature and you told about the condensation. Now next, what you also told about the umbilical cannulation, told about the pulse oximeter probe. Okay. And where are the cannulae?
Cannula left, right upper limb.
Why there are two cannulae?
One cannula and one central line.
No, there are two cannulae in the right upper limb, isn't it?
No, sir. Only one.
Only one? Okay, so I can, okay. Okay, any redness there?
No, sir. No
Okay.
redness or swelling, sir.
Yeah, take it. Good. So after you describe the head to toe and then you talked about the vitals, did you tell about the blood pressure?
No, sir.
So always in a sick baby, blood pressure should be told about both systolic, diastolic, and a map. Okay. So you told about the heart rate, saturation, CFT, blood pressures. What else?
Pulses.
Pulses, yeah. CFT, pulses, and peripheries. And then weight, length and OFC. If you know, you should tell that also because anthropometry has it. Do you need to assess gestation of this baby?
Because less than 7 days, we can assess gestation also.
Very good. So more than 7 days, we try to avoid assessing because it may not be correct. And what type of examination is important in this baby? Now, this is a preterm 29-weeker 7th-day baby. So what will be our goal? What problems this baby may have now?
Then respiratory abdomen also we need to assess.
Okay, why need to assess that?
Chances will be more.
What?
Easy chances.
Okay, so you need to see early signs of NEC are there, or nutrition, how is it going on for this baby? So do we know, looking at the abdomen, you feel it is all right?
Yes, sir. No fullness observed.
So no fullness. And any aspirates are there in the ET tube?
No aspirates in OG tube, sir.
Okay, can you open the diaper and see if there is any stool and what is the color of the stool? Has the baby passed any stool?
No, sir. Baby didn't pass any stool, sir.
Okay, good. So abdomen looks all right according to you. Okay. So are you worried about the breathing of this baby, or you think breathing is adequately supported?
It was comfortable, sir, because SA score was only 1.
1. So why did you say SA score of 1? Can you tell me the components and then describe the component in this baby?
Sir, 5 components, sir. Upper chest retractions, lower chest retractions.
No, you tell the upper chest. What is upper chest here?
Sir, upper chest only visible lag was there, sir.
Okay, only upper chest, visible lag. You saw. What do you mean by visible lag?
Between abdomen and chest, there will be asynchrony.
Okay, good. So then lower chest.
Lower chest, no retraction, sir.
Okay, what is the third component?
Xiphoid, sir. No retractions in
Very
xiphoid.
good. So what else? Fourth?
Nasal flaring.
Okay. Though any nasal flaring is visible.
No visible nasal flaring, sir.
What is the fifth component?
Grunt, sir. No audible grunt. With steth also, it's not audible.
Very good. So you know that breathing is Silverman scoring 1 is acceptable for a baby on bubble CPAP?
Yes, sir.
Yes. What score is acceptable?
Up to 5 we can.
Up to 5, 29 weeker?
4, sir. Up
to 3.
3.
To 3 is acceptable, but it should be a slowly improving score. Okay, now you said in a PEEP of 5. So does it require more PEEP in this baby?
No, sir.
No. FiO2 you said 25. Is it okay? Why is it okay?
21%.
21. Okay. So do you need to give 21%? What should be the expected saturation?
90 to 95.
90 to 95. But this baby, so if your baby is on room air, you expect 90 to 95, or what should be the saturation of a baby on room air?
Maybe it is more than 95.
Why this baby should be 91 to 95 then?
To prevent ROP and
No.
BPD.
Normal room air 95 and above, but this baby saturation target is 91 to 95. Why? He is like in room air only, no? 21% oxygen. But you are said that this baby saturation should be 91 to 95. Why it should be 91 to 95 and not above 95?
Free radical injury.
Didn't get the question. What is the saturation target for this baby? Is on 21% FiO2. What is the target saturation for this baby?
More than 95.
So this baby is on respiratory support.
90 to 95, sir. Very
So babies on respiratory support, irrespective of FiO2, should be on 91 to 95%. Okay. So humidification, you said, is all right. So how can we say humidification is all right? What points you have told about that? Can
No
you show?
inspiratory limb, sir. No
Yeah,
con-
so no condensation in inspiratory limb. Look at the water level in the humidifier and tell me how much is the water adequate.
up to maximum level, sir. Adequate.
Show the water humidifier chamber. So water humidifier chamber. Is the water adequate? The level of water in the humidifier chamber is adequate? Is it excess or adequate?
Adequate, sir. It's
So
up-
does it have an auto flow? Does it have an auto flow? Show
No.
the water, show the distilled water connected to the water flow, to the humidifier.
It's there, sir.
So is that the way that should be? What will happen if you keep it like that? Where should that be? Where should that humidifier bottle chamber should be?
Should be hanged up.
Why should it be hanged up? What is the problem if you keep it down there?
Negative pressure will come down.
Okay, so the water will not flow in, and then you may got evaporated water loss, and then still the baby will burn, because if water is not there in the humidifier, inadvertently high temperatures will be given for the baby. Okay. Now look at the bubble chamber.
Yes, sir.
Look at the bubble chamber.
Bubble.
Water level is good.
Yes, sir.
Okay, good. So bubbling is continuous or is it intermittent?
It's continuous bubbling is there.
What is the need for the second chamber in the bubble chamber? What is the need for that second chamber? That one, yeah. There are two chambers, one is water filled, other one is. What is the need for that second one?
To empty the maximum levels.
So what will happen if that chamber is not there?
More people.
More people will be delivered. So, but where do you get excess water from?
From expiratory limb.
Very good. There could be condensation in expiratory limb, and then water can flow into the jar. That is why you need to avoid that. Okay. Okay. Now, where is that? Show me the pressure, the safety valve. Show me the safety valve. Where is the safety valve in the CPAP circuit?
This is not.
So this is rest, so it's inside only, sir.
Okay, good. Okay. So how much is the measured pressure?
Measured pressure 4.7, sir.
Okay, 4.7 is the measured pressure. Set is 5.
That is 5, sir.
What type of interface you're using?
Ram's cannula, sir.
Go back to the nose of the Ram's cannula. So how is it fixed?
Snugly fitting, sir.
Snugly fitting, and you are used a cannulate, correct?
Yes, sir. Neo.
The cannula be used for a Ram's cannula?
Yes, sir.
So for a Ram's cannula, we should avoid using cannulate. There should be only 80% of the nose should be occluded.
Okay, sir.
So do you know the flow, how it happens in Ram's cannula versus other cannulae? Do you know how the flow in a Ram's cannula versus other cannulae? How the inspiratory gas will come to expiratory limb? How the inspiratory limb gas will go to the expiratory limb in Ram's cannula versus other cannulae? Okay, homework for all of you. Okay, how the air from the inspiratory limb will go to the expiratory limb in Ram's cannula versus other cannulae. Okay, so do we feed this baby?
Yes, sir.
So is this, what type of feed this baby should be on?
Exclusive breast milk is 3%, EBM, followed by donor milk is on.
Why do you think this baby is still on CPAP? 29 weeker, 950 gram is on 21% oxygen. Why this baby is still on CPAP?
Baby had apnea, sir.
Okay. Why he has apneas? What do we do to prevent apneas apart from giving CPAP?
Caffeine we need to start with.
Is he on caffeine or not?
The baby some caffeine.
Okay. So what else?
Okay.
So what else is the reason for apnea in this baby?
This baby initially borderline sugars were there, sir.
Okay.
Because
What else? What are the other reasons for apnea in a baby like this?
sepsis could be one.
Sepsis. Now you think the baby has sepsis? 29 weeker, 950 gram. Why should it be on CPAP? One reason could be apnea. What could be other reasons for baby on?
One secondary causes like IVH, metabolic causes.
Okay, good. IVH. Do you think this baby has IVH?
No, sir.
Looking at the baby, do you think the baby has IVH?
No, sir.
Why do you think the baby doesn't have IVH? You've examined the baby, and why do you think the baby doesn't have IVH?
There will be irritability, it's not there.
So, baby's sensorium, how is it? Good. Is he responsive to stimuli?
Yes, sir.
Does he have spontaneous activity, spontaneous movements?
Yes, sir.
Does he have pallor?
No pallets.
Symmetry of movements is good.
Yes, sir.
Okay, so a baby who has all this is unlikely to have a major IVH at all. Okay. So what else? What are the other reasons for baby to be on respiratory support at 1 week of age? 29 weeker babies, what is the commonest respiratory?
RDS, respiratory distress.
That is over now. So what will that RDS lead to later?
Pneumonia.
Why this baby continue to be on respiratory support?
BPD.
BPD. So when do you call this baby have what is the name you give now if this baby has respiratory support? At 1 week, the baby is on respiratory support. You call them BPD or something else?
Evolving BPD.
Evolving BPD. So it could be evolving BPD. So how CPAP will help in evolving BPD? What is the main etiology of BPD or pathophysiology of BPD? What 3 components of the lung are affected in BPD?
Volume.
What?
Lung volume, sir.
Lung volume or alveoli. What else? Alveolar affected and what happens to the airways?
CPAP helps in splinting of airways.
Very good. So CPAP helps in alveoli as well as in airway dilatation. Okay. What is the third component of?
It improves ventilation perfusion mismatch will be decreased.
Very good. So it also helps in matching the VQ. So vascular growth also improves. Okay. So it prevents PPHN. It prevents, it promotes lung growth and it will help in airway dilatation and improves the breathing support. So it is one of the best therapies for evolving BPD. Correct? Okay. So Tejo.
I think most of the questions are done. How many minutes we have only right now?
Feedback, actually, both of you can give the feedback to presenter C, because C presented asked all the history in very detail, and Sir has asked all the journey of CPAP. Murthy Sir has asked all the questions. She presented with physical examination also. But for benefit of all the students, one feedback is summarizing the feedback 2 minutes at least we can talk so that all will learn what to think not to miss.
From my side, I think you can focus a little more, like when we tell about the opening statement, what we have given you the history, you concentrated more on the antenatal and birth details. Even after that, also postnatal, like suppose this baby might have had a PDA or something like that. So what was the course and what was the, does the baby at any time attempted to remove from the CPAP or not? So all these things are also important details that you can grasp because you'll be able to come to the diagnosis. At the end of the day, in the last survey has asked you, what could be the reasons for this baby to be persistent on the CPAP? So even those things are also important. And some relevant questions like how can we prevent BPD? So those specific history also you should try to take it if possible. And while examination, I think that sequence what sir has told you to follow. So one is that first describing the baby overall with vital signs, and don't miss on the blood pressure or anything. And then describe the baby head to toe. Then gestational age baby is very in the early gestation. And then if you anthropometry, comment on anthropometry also, because if you're having a baby who is less than 72 hours or less than 7 days, you can even assess the growth status of the baby also. Sometimes birth weight might have been measured incorrectly, but if you should look for the intrauterine growth status also postnatally in the baby, like having more skin folds and all those things, we should try to examine. So, and then in the specific examination, I think you have done reasonably well, but while the baby is on nasal prawns, it is difficult for anybody to comment about the nares in the Silverman scoring. Okay, sometimes you will unnecessarily get trapped. So be specific on those things and then try to interpret the signs also. That is also an important thing. I think even in the previous case also I was telling the same. So while you describe that the heart rate is 150 to 160, whether it's a normal or abnormal. So respiratory rate 44, whether it is a normal or abnormal. Silverman score, why you are saying it is a normal. So those things are also very important for you to do it. And maybe if you have time, I think we could have gone into that. How do you plan this baby to come out of CPAP and other things also? You should try to keep a plan while you are at the end of your examination and everything. Because in the exam, again, they will try to ask you about the same, because how do you manage this case after this? And then those are the important things that we need to look at. Okay. Sir.
So, yeah, as Tejo told, I would suggest that you spend maximum time with the babies in the NICU. You will never have any problem in the exams. Okay. So these are the typical babies you will get in the exam, and it's always a cracked or a leaked paper. Okay. So if you get a preterm baby like this and on a CPAP, it's a leaked paper. It is already known that they will ask you about the opening statement, how it should be, steroids, max self, place of delivery, cord clamping, then obviously the reason for delivery, if it is a preterm, and reason for delivery, and if there is an emergency, why emergency. Okay. And then the delivery room resuscitation details, special thing about preterms, and admission details, and admission CPAP, admission surfactant, admission caffeine. One very important thing is TPN. So starting amino acid at birth and then progressing to full enteral feeds by as soon as possible. 5 to 7 days, baby should be on enteral feeds. Now, first 1 week, our concentration is on respiratory, nutrition, mainly parental nutrition, IVH, infections, and and PDA. So first 1 week, we'll be concentrating mostly on respiratory, IVH, PDA, infections, and parental nutrition. 1 week is over, all the things, major things are out. So then it will be a growing baby where your concentration is on growth and nutrition, and probably evolving BPD and some infections. Okay. So your PDA is out, your IVH is out. Then you are talking more about infection, nutrition, growth, and some respiratory support, which is a lingering support. Okay. So if you get a baby like this, it's a leak paper. So you should know all those, everything, because this is 90% of NICU. Okay, good. You've done a very good presentation, and keep it up. Only the order and I think synthesis is important. Keep presenting more often and do that every day, so that in exam it is just another day. Okay.
Thank you, sir.
So this is actually the mock examination. The purpose only to train. So to all the exam going trainees here, so I agree with Murthy sir. All the students, for the long question is leaked now. The long case is leaked with 70 marks. I wish all the students will secure 65 to 70. And the next question, next presentation is coming, the short case we are going to leak you. All the big people will get one long case respiratory sick and ICU babies, one feeding growing babies, which will come to the next presentation. So before closing, I will see this presentation is very typical the way covered now. 2 components, as Dr. Tejo also told. End of the presentation, the examiner may ask you plan for today's round. You have given a clinical round, give the exit plan for today and for the next few weeks for the baby. That may be added. The investigations and the treatment plan, maybe they will ask, write down in your cases, what is the exit plan for today? And second component is the parents are there or a simulated parent staff. Nursing staff can be parents. You explain the family. Now you finish your round, explain the family, what's further you are expecting. These two components after presentation may be common for all the cases. All respiratory cases or sick NICU cases, giving plan and speaking to the family. Maybe part of the presentation, last 3-4 minutes of your case discussion. That's a constant we discussed in the previous case also. So with this, I thank both the examiner, Murki sir and Dr. Tejpata, and the student Soilu sir. She presented well, covered all the aspects of CIPA from the history taking examination, answering all the queries. So with this, I will request Dr. Rishikesh Thakre sir and Dr. Arjit Mahapatra sir both join for the next case. But any inputs quickly for one-on inputs for this respiratory case, then we'll invite Dr. Manisha, who is going to present the case from Amri Hospital, Bhubaneswar. So in the meantime, when Dr. Manisha is getting ready, Rishikesh Thakre sir and Arjit Mahapatra sir, both, if we can one-on inputs for this respiratory case, it might help the students. Rishikesh sir, welcome and good evening, sir.
Good evening. I think it was a very comprehensive presentation. At the end of history, it is better to highlight what are the risk factors that you have identified, what is the things that went right, because that is where at the end of history you would be stopped and you would be asked to analyze your history, and you would be asked to know the details of what you think were the risk factors, what happened, what could have been done right. And obviously focus more on examination to describe the baby in such a way that the examination, your description itself becomes self-explanatory. Means rest of the things becomes more obvious the moment you describe head to toe. I think if you spend at least 3 to 5 minutes just describing the baby head to toe, it will be giving lot of information. Secondly, also talk about nursing interventions which have gone on the baby, which will reflect the care which is happening for the baby. And I think the more you practice, the more lesser the mistakes you make. All the best.
Thank you.
Thank you, sir. Arjit sir, anything, any inputs to the respiratory case? Then we'll move to the feeding growing case where you are cross-examining the presenter. You both will
thank
be
you, thank you. It's almost everything is covered as Dr. Murki told. It's like a licked paper. It is a standard and set case. A premature baby having on NIV and different aspects. And as in the previously, Dr. Dinesh told that you can direct your questions in that way. So for that, you have to keep on practicing and practicing. So practice, 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 so that exam becomes any other day. So that should be the thing. But she has presented it very nicely. So only the order has to be in place.
So thank you, Dr. Soilu sir. Then we'll move actually. Dr. Manisha is waiting for presentation, and that will be the third case in the sequence. One ventilated case we have taken care in NICU, probably extubated to CPAP or primarily CPAP supported in the next case. Then the third case is after respiratory system support is over, a baby is growing. That the third baby majority time, the stay time, the NICU care involves for a feeding growing baby. The care and the plan, both we should learn from a feeding growing babies. And half of the neonatology book sometimes we learn from a feeding growing baby. So with that, probably Dr. Manisha is going to present a feeding growing stable baby in NICU. So from which, and the presentation time, I will request 15 minutes. You can present, and both the examiner, Dr. Rishikesh Thakre sir and Dr. Arjit Mahapatra sir will cross-examine next 15 minutes and give the inputs and feedbacks later. And with this, the opening sentence of the one of the faculty or the resident doctor there from the Amri Hospital can opening sentence, few of the facts about the baby can given to Dr. Manisha. If she needs something specific, she will answer as a question history. Otherwise, she will directly present about the case. Please proceed.
Good afternoon, everyone. This baby of Sarika Begum, this was a male child. He was born at 29 years 4 days, gestational age, by emergency LSCS. The birth weight was 1300 grams. The indication of LSCS was oligohydramnios. The baby cried immediately after birth. Apgar score was 8 and 9, respectively at 1 and 5 minutes. But 30 minutes after birth, the baby went into respiratory distress. SAS score we calculated, it was coming as 6/10. So the baby was put on CPAP with the initial settings of FiO2 of 30%, PWF of 6. Then over the next 48 hours, the baby was went up to room air. TPN was started from 2 hours of life. Then oral fluid we started at 12 hours of life. Then gradually TPN was decreased and full oral fluid was made by day 7. When the baby was at the rate of 60 ml per kg per day of total food intake, HMF was introduced. Now the baby is on room air, maintaining stable vitals. The post-menstrual age is 33 weeks and the present weight is 1500 grams. Now,
So Dr. Bhatia, today you got lucky. You got so many details, but the opening sentence will contain only 3 lines with the biological risk factor of singleton, tween, SGA, AGA, boy baby, girl baby, birth weight, and gestation. And the important course 1 or 2, and you will come to the present day in the feeding growing babies. Few details, and you can start presenting. That's the protocol. That's the pattern normally we do. So you got more detail. It's okay. If you sometimes you don't get detail, you 1 or 2 questions you can ask the support team, or nursing staff or doctor available during examination. So you can start presenting, Dr. Manisa. With permission of both the examiner, you can proceed and they will further listen and ask the questions.
So my baby is a 23-day-old baby with PMA of 33 weeks, born at 29 weeks, 4 days. Indication of emergency LSCS was oligohydramnios, and the baby after being born, baby had respiratory distress. So baby was taken to NICU and put on CPAP with PEEP6 and FiO2 30%. Then gradually baby was weaned out to room air on 48 hours of life. Baby is now maintaining in room air. My baby's weight is 1500 grams, taking calories of 130 kilocalories, protein of 3.8 grams, carbs of 22 grams, 5 grams of fat, and 20 grams of calcium, and 220 mg of calcium, phosphorus 113 mg, and vitamin D 770 international units.
Okay. So, as per you, this appears to be a well baby, and who is in the nursery following a little turbulent course, but otherwise is doing well as of now.
Yes.
So it's a stable baby who is there for growth. That is what you are trying to tell us.
Yes.
Okay. At this stage, on day 23, that you are on rounds for this baby,
Yes.
what specific things you would look for on clinical examination that will alert you that something is wrong with this baby?
If any signs of sepsis,
So tell me what specifically signs of sepsis you are looking for.
any CRT is more delayed. If there is cutis marmorata, if the baby is lethargic, not feeding well, vomiting, and
Okay.
if
So-
feeding intolerance is there.
Yeah. So this baby will show you subtle signs in the form of change in the heart rate pattern, change in the breathing pattern, change in the sensorium. So vital parameters are the ones which would be the first that you will pick up. And so also anything specifically that you would be.
Tachycardia will occur first. Tachycardia will occur. Urine output will decrease.
Okay, so at this stage, with the vitals being otherwise stable,
Yes,
what would be your comment as far as the weight of the baby is concerned
sir.
compared to the birth weight?
Birth weight is appropriate for gestational age, sir. Yes,
Correct.
Sorry, birth weight is in 10 centile, sir. 1500
it's-
grams, 40
So, what is your comment as far as the weight of this baby is concerned compared to the birth weight?
Baby is gaining 20 grams per kg, 20 grams per kg per day, sir. According to that, birth weight is he's gaining appropriate weight.
Okay. So, what growth chart did you use to identify this growth pattern for this baby?
Intergrowth 21. Sir.
So, is it what type of growth chart is it?
It is a postnatal growth chart.
Okay. What do you mean by postnatal growth chart, and in what way does it differ compared to intrauterine growth charts? Why did you choose the postnatal growth chart? Okay. Do you know how the intrauterine growth charts differ compared to the postnatal growth charts?
Well, in intrauterine growth chart, we can assess up to from 25 weeks to 50 weeks.
So no, either of the charts could be used for growth monitoring, isn't it? See, whenever you use a growth chart, you have to identify what type of growth and what is your purpose of looking at the growth. So if you are using a postnatal chart that you talked about, it is a descriptive chart. It tells you what the actual growth of the baby is. And it was collected based on data from a longitudinal population screening. And it is meant for postnatal growth primarily. But if you're, and it takes into account the postnatal weight loss, which takes place in the first week. But if you use an intrauterine growth chart, these are prescriptive, they are from cross-sectional population, they do not take into consideration the weight loss, and there is likelihood of you putting most of these babies extrauterine growth retarded, and they are good for predicting the birth weight. So I agree you took the postnatal growth charts. Do you know any other growth chart apart from the intergrowth 21 chart that you have?
WRS, MGR chart, MGRS,
Okay.
And for intrauterine Lutsenko's and phantoms.
Fine. So those are some examples of the chart that you talk about. So at this stage, with this growth chart, and so the baby is on the 10th percentile. So would you label this baby as IUGR or would you label this baby as EUGR?
EUGRs.
Pardon?
EUGRs.
Extrauterine growth restriction. But just now you told me that the weight of the baby is doing well and you are happy with the growth of this baby. So why do you think this baby you are labeling as extrauterine growth restriction? So at birth, was this baby AGA or SGA?
AGS.
AGA. And on what percentile was it on at birth?
At birth, also 10 centimeters, below 10 centimeters.
So below 10.
Between third and 10th.
So do you think the baby is following the same trajectory since birth, or do you think the growth of the baby has dropped its trajectory, or is it higher than its trajectory?
So during birth, it is 50 and 19 centimeters.
So 50th percentile.
50 and 19th percentile.
50th and 90th percentile.
Yes.
And now it is 10th percentile.
Yes, sir.
So this baby is obviously showing extrauterine growth restriction, correct?
Yes.
So even if you are showing a rise in weight, so do you think, what do you think is the cause for this extrauterine growth restriction? So this appears to be pathological, not physiological. So what do you think will come in the way of the baby's weight on day 23? Because on one hand, you appear to be very much at ease with the way the weight is growing. But when you plot this chart, weight on the growth chart, to your surprise, the baby is not showing growth. In fact, it is showing drop in growth. So tell me, with this understanding, what will you assess the baby for? So what are the common causes that will tell you that the baby is not growing well?
if the baby has any congenital heart disease.
Very good. So you would assess this baby for murmur. You would assess this baby for its oxygen saturation. But the very fact the baby is in room air, without any support, it tells me that the respiratory and cardiovascular status is stable. Okay, so you have ruled out major respiratory and cardiovascular anomalies. What else can come in the way of growth for this baby at day 23 that you said?
Anemia of prematurity, osteopenia of prematurity.
Okay, so anemia of prematurity, but anemia of prematurity, I am told, will come at 4 to 6 weeks of age. Or is it physiological anemia?
Maybe physiological anemia.
But
After
physiological
birth.
anemia comes at 4 to 6 weeks of age. So what anemia is this?
Due to frequent blood draw.
So the commonest cause, if the baby is anemic, you would identify it as iatrogenic, isn't it? So it would be a good strategy to mark the amount of blood that is withdrawn at every stage that you do an evaluation for this baby, isn't it? So one could be that this could be anemia, and which is probably iatrogenic anemia. Remember anemia of prematurity. How do you confirm that this is not anemia of prematurity or it is anemia of prematurity?
So by doing retic count, peripheral blood smear.
So what do you expect in anemia of prematurity?
Retic count will decrease. If that retic count is decreasing, then baby is producing
So your anemia of prematurity, do you think there is any test that will confirm your diagnosis? Or is it a diagnosis of exclusion?
exclusion.
So it's a diagnosis of exclusion, isn't it? So there is no gold standard test. So you say that it is not hemolytic, it is not because of suppressed marrow, it is not because of blood loss. And in this setting with that preterm baby, you would therefore retrospectively say that this is anemia of prematurity. So it could be anemia of prematurity. Could you have prevented this anemia of prematurity?
Yes, sir. By adding iron in supplements.
So for an ELBW baby, at what stage would you have started iron for this baby?
2 weeks after.
So 2 to 3 weeks, especially if the baby is stable and is free of infection, that you would consider starting. So it could be iatrogenic anemia, it could be anemia of prematurity. Is there any other strategy by which you could have avoided anemia of prematurity in this baby? Something which is to be done for every baby at birth. Simple, low cost, effective, evidence-based intervention. And more the reason, very good, very good. So delayed cord clamping. So simple strategy that could have reduced your need for transfusion and reduced your need for, and give you a better stability in terms of hematological parameters. Any other intervention? Do you give any drug that could have prevented this anemia of prematurity?
Antenatal corticosteroids.
Antenatal corticosteroid will not prevent anemia of prematurity. It has no action on that. It has the action on RDS, death, PDA, IVH, NEC, your circulatory stability. Any drug that would have prevented anemia of prematurity, some of the units would be using it.
EPOs.
Pardon?
Erythropoietin.
Erythropoietin. Very good. So that is one drug that could be used prophylactically, or it could be used therapeutically, but not a standard of care for babies with anemia of prematurity. So one cause for your baby not growing well is anemia. Most probably it is a combination of both iatrogenic and anemia of prematurity. Okay. Any other cause that would tell you that this baby is therefore not growing well? And,
Feeding.
Pardon?
The feeding by the mother, if the feeding is for hypothermia also.
Okay, so thermal instability. thermal instability will come in the way of growth of the baby. So it's not hypothermia, it is variation in temperature, or because it's very unlikely that a baby in the NICU, a 29 weeker, is being subjected to hypothermia. It's unthinkable, isn't it? And very impractical also. Most probably, there could be a component of thermal instability that could have added to this. Any other medical disorder which will come in the way? You said sepsis, but sepsis is unlikely simply because your baby is having vital stable, the activity, tone, cry is good, and you're documenting weight gain. So sepsis, very good. So what electrolyte imbalance would you expect in this baby? Okay, so that is the electrolyte imbalance which will come in the way. And hypocalcemia. Osteopenia of prematurity, yes, you could have, but it will not come in the way of growth of the baby, isn't it? So it is something which will be picked up incidentally, but not coming as growth failure. Anything else which is unique to preterm babies, extreme preterm babies, which will cause growth failure? So you talked about thermal instability, probable sepsis we said is not there, anemia of prematurity, iatrogenic anemia, yes, electrolyte imbalance, yes, possibility of a congenital heart disease, unlikely, that you said. Any other?
Kidney
Is there
disease,
anything? Pardon?
For this baby, sir?
Yes, 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 for this baby.
Any underlying kidney disease?
Okay, so you have some form of metabolic acidosis or a late metabolic acidosis setting in, or you have a renal tubular acidosis kind of inborn error, which is coming in the way of the growth of the baby. In that case, the baby would be not showing weight gain. The baby would be breathing fast. And what is the clue to you that this is renal tubular acidosis? What is the hallmark? Because there it will show you metabolic acidosis. What is the clue on metabolic acidosis that tells you that this is not a metabolic acidosis because of anemia, sepsis, renal failure, lactic acidosis, inborn errors of metabolism, or poor perfusion? All of those would come with metabolic acidosis. So also renal tubular acidosis.
NN gap, normal NN gap.
Very good. So a normal or a decreased NN gap is a clue to you to say you are dealing with a renal tubular acidosis. Okay, get out of that electrolyte imbalance. What iatrogenic factor will cause the baby to not grow well? And it has happened because of the baby being extremely low birth weight, very preterm, of all the interventions you did, CPAP that you did, the lines that you put, the antibiotics that you gave.
Baby is in now baby is in room illness, sir. No BPD.
Yeah, so I'm not talking about BPD. BPD, that's what I said. You don't have a significant respiratory or a cardiovascular disease in this baby. It's all out. Because the very fact you are on room air and your vitals are stable. So that rules out cardiorespiratory instability. So tell me an iatrogenic disorder which will cause the baby to end up with similar kind and allow the baby to go 1 week down the line, and you will start having this baby having apneic spells, gastric residues, and you have an unexplained thrombocytopenia which is coming up, and then you find this baby looks pale but is not anemic, looks icteric but looks jaundiced but is not is looking unwell but is not sick, and there is an upcoming. Pardon?
Somebody's answered, sir. In the I'm asking, giving a clue to the student.
The clues are to the student only. So any iatrogen, so any baby with 2 weeks or a week stay or more in the nursery and has received a course of antibiotics or has had interventions, what would be the commonest infection that you would see in this baby?
Fungal.
Very good. So fungal sepsis. So that is something which will go unnoticed unless you have an open eye. And we do know that 2nd week and beyond is the time when if the baby is having any of the problems, one of the things that you would say is it an iatrogenic problem? So we have said, is it fungemia? Isn't it? So these are possibilities that you need to look at if the baby is not gaining weight. But are you happy with the fluid that you are giving, the amount of calories and the proteins you are giving?
Sir,
On day 23, you said 130 calories per kg per day, isn't it? So that is good enough. Your protein intake is also good enough.
Yes, sir.
So despite having an adequate nutritional supplementation, you find the baby not growing well. So obviously it should ring alarms somewhere to say, am I missing on any of these? Okay, tell me an occult problem that you are going to miss in this baby. So unless you hunt for the baby, now you have to start hunting for a possible underlying pathological cause for the baby who you have partially treated, but which will come with failure to thrive or extrauterine growth restriction. Because you have ruled out a nutritional cause simply because, and obviously you will counter check that the calories and the proteins that you said are really being delivered to the baby or not. Because there may be a gap between what you have prescribed and what is being delivered. Okay, so tell me what are occult problems now that you would look for, which have got either partially treated or you are likely to miss unless you make a search for these. So henceforward, every baby in the nursery should have a search for these occult infections. So one was fungemia. What else is an occult infection which is going to get missed? Okay, tell me all infections which could end up in chronicity. So tell me chronic infections of newborns. That is what you have to hunt for this in this baby. What are chronic infections in the newborn? All newborns have acute infections unless proved otherwise. But when you enter into second week, you have to think of something which has happened at birth, but which is now manifesting later, or something which was chronic to begin with, but has manifested acutely, isn't it? So what are chronic infections that you know of? Acha, tell me any baby where you have hit with antibiotics for a 2 or 3 weeks or 4 weeks period. So I'll tell you those are the ones which you have to search for in this baby.
Sir, any congenital infections like torch?
Okay, so intrauterine infection, torch group is one. So look for subtle clues in the baby. So look for hepatosplenomegaly, look for the eyes, look for the head circumference, look for upcoming jaundice, look for thrombocytopenia, because one of the clues will come from there. Most importantly, look for in the mother and more, so also in the family tree. That will give you a clue. So one is intrauterine infection. So that is one which is occult, which will be missed. So for which you will have to search for the cause for the baby. Okay, what else? What else? But you don't need give long antibiotics for intrauterine infections. You give long antivirals, isn't it? Of which the commonest is CMV. And if the history was there, or you have human herpes virus 6, which again would need an extended period of therapy. Okay, fine. What else will require chronic antibiotic therapy? So that is what you have to not miss in this baby. Okay, you gave antibiotics, you partially treated, and this baby ends up now, now that you have started to look for this with an elevated CRP, and 2-3 days later goes into apnea or throws up a seizure. What have we created or what have we missed?
Meningitis, maybe LOMS.
So yeah, so this is something which unless you look for, even if there were no risk factors to begin with, late onset sepsis is something that will come in the way of failure to thrive. There are two commonest late onset sepsis. One is your meningitis, the second is your fungemia, which cannot be afforded to miss. Okay, any other condition which will come, therefore you will have to look for again, which is going to require extended period of therapy. So you treated for thinking that it was sepsis, but now on the bedside you find that there is asymmetry of movements. What has happened in this baby?
Stroke, sir.
Pardon? Stroke. Stroke will, that is possibility, but why should stroke come suddenly in a baby who was otherwise well? So I am saying which requires chronic therapy. So we are still on that clue of chronic. Yeah, so a deep-seated infection is what is going to come in this baby, which will come with failure to thrive. And these are all subtle, and therefore your evaluation should start looking for all these things which will come in the way of the growth of the baby. Okay, so at this stage, we have identified based on that the baby appears to be well, but the baby, despite nutritional supplementation, is not showing growth. In fact, there is a weight loss which has the growth trajectory has gone wrong, and we thought of these common conditions. And last but not the least, whenever you have any of the babies who is not thriving well, inborn error of metabolism always has to be kept in the back of the mind. So those would be the clues to you to say possibility of these are there, which will come in the growth of the baby. You said that this baby is on supplements, nutritional supplements, correct? So, and you said one of them was human milk fortification.
Yes, that's it.
So, what is your strategy of giving human milk fortification? When do you start? When do you stop?
At present, when the baby acquires oral feeding of 50 ml per kg per day, then we will add.
For all babies? Which babies would you target?
Low birth weight.
Low birth weight are all babies less than 2.5 kg. So you would want, so half the India would be getting HMS, that means. So which category of low birth weight babies specifically?
1.5.
Yeah, so babies less than 1500 grams, so very low birth weight babies, or babies less than 32 weeks of gestation. Those are the targeted babies who, once they are at least on 50% of their enteral feeds, you would start with human milk fortifier. Okay, so these babies on human milk fortification, correct? If this baby is on human milk fortification, what supplements you will add which will not be there in the human milk fortifier?
Iron and iron we will add.
So
and,
iron,
we have to add some amount of calcium we have to add.
Okay, so you want only calcium or
Calcium and phosphorus.
Okay, calcium and phosphorus. So tell me an example of iron that you would want this baby to receive. What iron are you prescribing? What iron molecule are you prescribing? So I give you a choice: ferrous form, ferric form, colloidal form, IPC form, hemoglobin extract form. Which is recommended for supplementation for these babies?
Ferrous.
Yeah, so ferrous or ferric either are okay. So ferrous or ferric form would be the one that you would describe. Okay, and what preparation for calcium and phosphorus would you want this baby to receive? So what preparation you are giving to this baby?
Calcium piece of calcium.
Okay, so how much is the calcium per 5 ml and how much is the phosphorus?
300 mg.
300? Okay, there is no preparation in the market which gives you so much of calcium.
150 ml mg per.
Yes, so majority of the preparations have 150 milligrams of calcium with 75, and there are only select few preparations which give you calcium and phosphorus. Majority will be with calcium, they will not contain phosphorus, and therefore beware of your supplementation that you are giving. Okay, so one, you will supplement this baby who is on HMF with iron. Second, you said calcium, phosphorus. Anything else that you would want this baby to be supplemented?
The vitamin D is they are getting 800 units.
So vitamin D is already there.
Yes.
Okay.
Other vitamins, multivitamins you can add.
So multivitamin, do you want to add? Because this is on mother's milk, or you are on formula milk, or you are on donor milk.
Mother's milk.
So routinely, would you want this baby to be added on multivitamin? No, it will not serve any added purpose, isn't it? So minimum that you have to give is iron, calcium, phosphorus, and vitamin E. So that is mandatory. What about putting Simile MCT? Do you use Simile MCT?
Yes, sir. Yes, sir. Yes.
Very good. Yeah. So for growth of this baby, do you think Simile MCT will serve your purpose?
Yes.
Okay. So what do you think is the dose of Simile MCT that you would want, and how much calories do you get? Is there any role of supplementation of Simile MCT? So which babies must receive Simile MCT versus do you think it is a good option to look at if you don't have adequate growth?
If the baby is not gaining weight, then 1 ml contains 9 calories.
Yeah. So if you see the role of giving Simile MCT for growth supplementation is next to none. It is not a good way for the baby to grow. So if you have to give Simile MCT, there is only one medical condition where you give Simile MCT. What is it? But if you have to use it, I will tell you the second option which you could try for in this baby that will help the baby. The medium chain triglycerides need supplementation in which subset of babies? Pardon? Cholesterol. Very good. So there is only one condition where you should routinely supplement with Simile MCT, and that is baby with neonatal cholestasis syndrome. Okay. But otherwise, for growth, it is not a very good option. Do you think you can use it for massage of the baby and it will also help the baby? So it is a good option if you have purchased it, not for growth, but for massage of the baby. So that will help the baby to grow. Okay. Do you think, how have you been able to get so much of mother's milk in this baby? Because you said you are supplementing on mother's milk with a human milk fortifier, correct? So how have you been able to establish lactational adequacy in this ELBW mother in a baby who was sick in the first week of life? So what strategies did you employ to ensure that you would get adequate milk for this mother?
The KMC, NNS, non-nutritive suckling.
So are you practicing KMC on this baby?
Yes,
No.
sir.
Or yes?
Yes, sir.
So you are practicing KMC, but KMC has come probably towards the end of second week of life once the baby went stable. But you can't start lactating during the second week of life. So something has happened prior to second week in the first 10 days when majority of the mothers would have stopped lactating. So, okay. So one thing that you could have attempted is KMC, which you have, but that is to maintain, not to initiate lactation. Okay. But tell me what else strategies you applied, because it gives me an impression that your unit is very proactive for lactational adequacy, especially for this baby who would have been otherwise at risk for having a mother with lactational failure. So what did you do apart from KMC? You did so many things. Your unit culture reflects that simply because the mother is having such good amount of milk that you don't even need a donor milk, you don't need formula milk. So if you have to look back, or if you had to go back to day one of life, in what way would you help the mother establish or maintain lactation in this baby?
So by proper counseling them.
So this counseling starts before birth.
Yes.
Okay, so first thing that happened was somebody counseled the mother prior to birth, and thereafter, right from the delivery room, somebody was assorted the duty to look after ensuring that she is counseled about lactation. What else?
Proper rest and
very good, rest. So counseling, rest, But key factor for ensuring milk output is?
In mental well-being of the mother.
Okay, so you talked to the mother, being a doctor, you assured her, so mental stress you looked after. What is the key factor? Pardon?
Expression of the milk.
Expression, yeah. So pumping, and pumping. That is the key factor that will ensure that the mother continues to have adequacy in terms of lactation. So somebody has to be after the mother to express the milk frequently, periodically, and that will be a long way in addition to other strategies that you have. And the other simple thing is 24/7 access to the baby. That again will ensure that the mother and the baby are on the same wavelength. So those were the things that probably helped you to gain that much amount of milk as far as the mother was concerned. So you had a human milk fortifier, but we realized it has some lacunae. So you supplemented it with some supplements in addition. And you took good strategies for ensuring these. What medications is this baby on?
Baby is on only mother's milk and HMF, sir, and other supplements.
Okay.
And caffeine.
Okay.
Caffeine.
What about caffeine? So when would you consider stopping the caffeine for this baby?
At 33 weeks, if the baby is doing well, sir, or we can extend up to 40 weeks.
Okay, so at least till 34 weeks, you would continue, and preferably at hospital discharge, if the baby has been apnea free for 7 days or more, you would get out of caffeine as far as the baby is concerned. Do you have you done anything for the baby that will help the baby long term in terms of screening at day 23 on a 29-weeker 1.3 kg baby?
Yes, sir. We have done. I have done ultrasound on day 3 of life, and we will be. I will be doing ROP screening on after 4 weeks, 2 to 3 weeks.
So, just let sorry, just for my understanding, what is your unit protocol for screening for ultrasound of the brain?
Ultrasound, sir. If the baby is doing well, then after baby being stabilized, we can. I can do after 3 days, day 3, and for ROP screening.
No. So, just get clear about the ultrasound of the brain. So, first ultrasound in the first week of life.
Yes.
Earlier, if the baby becomes unstable.
Yes.
But at least one ultrasound will happen during the first week. When else would you want the second or
36.
so? 34 to 36 weeks is the second one. And the what is the purpose of doing the first ultrasound, and what is the purpose of doing the second ultrasound?
To see for any IVH, sir.
So that was the purpose in the first week. To identify a baseline. Is there IVH sitting in? Okay, but what would happen?
We have to see for any PVL changes.
Very good. So the purpose of doing it 4 to 6 weeks down the line is to look for upcoming periventricular leukomalacia, or you would have worsening of your intraventricular hemorrhage, which is there. So that was your purpose. Do you agree with having this ROP screen done on this baby at 4 weeks, or would you want it to be done earlier? So if I was to be told, what are our
less than 28
national...
weeks, sir,
Pardon?
in less than 28 weeks, we can do in 2 to 3 weeks. If baby is more than 28 weeks.
So why did you say 4 weeks? This baby is not a candidate at 4 weeks. This baby is a candidate for, in fact, an aggressive form of ROP, and therefore at 2nd to 3rd week, this baby should have undergone ROP screening. Okay, what is new about the ROP classification? Which classification did you use for ROP in your unit?
NNF.
No. NNF would give you guidelines, but what classification do you use? So there is a chart, isn't it? There are 2 eyes, and it has zones, it has severity, it tells you the extent of the disease. So you mark it on the chart. So what is that chart, and what classification is the one? Yeah, so it is the international classification ROP. Which version? First version, second version, third version, or fourth version? Third or fourth? Third only. Yeah, it came out recently. So what are the changes which have happened in the IRCOP 3 that you should be knowing as a clinician? There are so many changes which happened, but they were meant primarily for ophthalmologists. So as a neonatologist, what are the implications of that IRCOP 3 for your unit?
Aggressive ROP.
So the term APROP is out. Now they have used only one term.
Aggressive.
Aggressive ROP. Okay, very good. What else? 2 more things that they have described. When to what is, one is of remission and one is of recurrence, isn't it? So those are few things which are of clinical relevance as far as we are concerned. So they have clearly defined what do we mean by these terminologies, and these are key that you would need to look for. And how do you prepare yourself for screening for this baby? How do you prepare for ROP screening for this baby?
I don't understand.
Okay, I am telling you that the ophthalmologist is going to come tomorrow morning for this ROP screening for this baby. So what instructions would you give to the staff that will help to ensure that it is a smooth screening which takes place?
Pediatrics will be put in the eyes.
But you can't tell the staff give pediatrics, no? She will say, tell me what it is. So what drops have you used? So you haven't done ROP in your unit? You must be doing, if you have such a small baby, so you have to be very clear about what, because you are the one who is going to instruct. Atropine. How can you give atropine to the baby? So you should know something that will dilate the pupil. You should know something that will serve as an anesthetic. So phenylephrine, 2.5%, tropicamide are the drops that you would give, and 1 drop every 10 minutes, 2 times that you will give, and after which your retina specialist or your trained pediatric ophthalmologist will enter to see. But there is one more instruction that you should give to this baby, to the staff. Pardon?
If the baby cries for sucrose solution.
Okay, so you gave sucrose 5 minutes prior, 24% sucrose, but I am sure you don't have sucrose in your unit. It's not available in India. So what did you give? Pardon? You can use glucose. Yeah, you can use dextrose. So why do you say sucrose? Books say sucrose, but you don't have sucrose. So, and as far as feeding is concerned, anything in special that you would want?
Sorry to interrupt, sir. Sorry to interrupt. Lots of learning going on, but we are at 10:18. So we have to wind up the session within the next few minutes.
Okay.
So quickly, you have to go, sir. You have covered all the journeys. As I told, the feeding growing baby teaches 50% of the neonatology book, not the critical care case. So it's happening. But so we have to wind up we have to go to conclusion. Arjit sir also can some inputs and questions. Then I will proceed, sir. So you close, sir. Your next 1 or 2 minutes you can close. Then we can proceed.
Yeah.
Arjit sir, few minutes. Then we can. Thank you, sir.
So what screening will you do? One screening that you will do on this baby on day 23 is, one is ROP Second, you said is hematocrit. That is for anemia, because that is the one which was the going to come in the way of your growth. Any other screening that you should perform, which will again come in your growth?
Electrolyte.
No. Yeah. So metabolic bone disease screening, but usually that happens at hospital discharge, not during the 3rd week. Not something that you would look for. Something else which is a treatable, preventable condition. The commonest cause of preventable intellectual disability is that you should screen. So, more the reason being preterm that at the end of 1st week that you would have screened. If you have forgotten or for some reason during sickness, if you have not done, you should screen now, because that is something again which will be worrisome to you. So I think that's it from my side. Over to Arjit.
Covered
Thank
well,
you,
sir.
thank
All
you.
the systems covered.
Thank you, Dr.
Before Arjit, sir, before you start, I just request all the trainees who are attending, little few left, but still 100 plus trainees are attending. I request only one thing. Before your nutrition calculation, please read which fortification your unit is using. There are not many. In India, only 2 products available. If you're not using from the mother milk source, you're using bovine source, only 2 products. Compositions are well written in the PAP sachet. Because a lot of confusion when I was watching the answers from the trainees. You got 120 units of vitamin D3 in one single sachet of HMF, the standard. So if you're using one feeding one, you're using how many? 12 sachets a day. In 12 sachets a day is giving you how many? 120 multiplied by 12, 1140 units of vitamin D3 you are giving. You are giving full 1 sachets. During half of that, you are giving 600 units from the HMF only. So are you still interested to give more? So you check it once. So these are 2 issues. One is the HMF you're using. Always include HMF's all nutrition. It gives a lot of calcium. 1 sachet gives around 18 or 17, 16 milligram of calcium, 8 milligram of phosphate in 1 sachet of HMF. It gives iron. It is enough multivitamin. I saw an answer. Should we add multivitamins? No, we should not add. A lot of multivitamins already there. The fat used in HMF is MCT fat, medium chain fats. Are you interested still to use? Those questions will come, but I'm highlighting HMF. Go to the composition, read it. It comes as Potter-Oski. It comes as a Biovab drug medicine, and as it comes as bedside when you will ask nutrition calculation, you have to use it. So please go through the composition. Use it when you're using how many sachets per day? 8 sachets, 12 sachets, or 6 sachets you're using. Combine in nutrition calculation, because the feeding growing baby, always that question comes. So that's the one message from me. And then I will request Dr. Arjit sir to few questions, few inputs, few comments. Then I will probably close the session. Thank you, sir.
Thank you, Nandini. It's almost very extensively covered by Dr. Rishikesh already regarding all aspects. I just have to add one thing, that the same question you just discussed. Which HMF are you using for your baby, this current baby in question?
Lactodex.
Lactodex HMF. Okay, so how much is the calorie content?
14 kilograms. 14.
Okay, so sorry.
14
calories.
1 gram contains 14.
One sachet contains how much calories?
14 kilograms.
Okay, so
No.
1 sachet you are
3.3.
No, it is 3.3. If a kilo choose 14, so wrong message. 3.3.
How much to how much milk you are adding 1 sachet?
25 ml.
To 25 ml too. So how many sachets in a day?
160 means 160.
How do you add? When do you add it? How much milk your per feed your baby is taking? How much volume of milk are you giving the baby per feed?
10 ml.
10 ml. What is the weight of the baby?
20 ml.
Sorry?
20 ml.
20 ml every
Every
2 hourly, 3 hourly?
2 hours.
Every 2 hourly, 20 ml. So that means you're giving 12 feeds. So 240 ml per day. So how much that comes per kg per day?
160 ml per kg per day.
So 160 ml per kg per day. So your baby is still not getting adequate weight. It's gaining weight, but not adequate, and landed up with UEGR. So what else you can do? You have already added HMF.
MCT oil we can add.
So with HMF, you want to add MCT oil. You're giving 160 ml per kg. So what else you can do?
We can extend up to 180. Sir.
Right.
200.
So what is the maximum volume we can go up to?
200 to 200.
So 200. So why not going to increase your volumes? Because you are giving just 160 ml per kg per day. So you can go up to 190 to 200 ml per kg per day. So that will increase your calories. So how much calorie you are giving the baby?
So 130. 130.
Per kg per day. So
Per
how much
kg.
more? How much more you can give?
So
Okay. So the babies you are
150.
giving oral feed or RT feeds?
oral artifacts.
Artifeeds. So what is the current weight of the baby on day 23? It's day 23, right?
Yes, sir. 1500.
So 1500 gram. What is the birth weight?
1300.
1300. So baby has just gained 200 grams. So when do you want to switch to oral feeding?
The baby is 33 weeks, sir. We are trying NNS and KMC.
Okay. What else you can do to enhance oral feeding?
Palliative feeds we can give.
Okay.
One or
What
two
else? Something very easy to do done by nurses. Low cost intervention.
Like non-nutritive sucking.
No, that you have already told, non-nutrition. What else? Oral stimulation?
Yes.
Okay. Colostrum painting? That is to be done in initial days. Okay, fine. So what else you can do? So you have to increase your volume. You have to already added HMF. So or the maximum volume we can go up to is 190 to 200 ml per kg per day. Suppose if the reverse is happening, your baby is normally we have 5 minutes, right?
Yeah. So 5 minutes we can conclude.
Okay, we'll wind up in 5 minutes. So suppose it's going the other way around. The baby is getting excessive weight. Suppose the 2 days round, the sister told baby has gained 60 grams weight. Then next day also 50 grams, like every day 50, 60. So are you worried?
Yes.
Will you be worried if the baby is gaining like 60, 70 grams per day?
Yes, sir.
So what could have happened? What is happening?
The risk of BPD will be increased now, sir, with more calories and
So there is some kind of water retention is there. Some kind of water retention there. So you have to look for your electrolytes. You have to look for renal functions and other things. The baby can be landing up in some cardiac issue also. Cardiac failure could be there also, right? So when do you switch to the baby was born at 33 weeks or 32 weeks?
29 weeks.
29 weeks. So you have got 23 means so you have reached at like 32 weeks. So another 2 weeks at least to go for oral feedings. So what other things you can do as a transition between artifeeds and complete oral feeding?
Already feed, sir, we can.
Palliative feed you can try. Okay. So but for that you have to the baby has to develop the Saksallo coordination, right? When does it develop?
NNS, sir.
When does the Saksallo coordination develops?
32 weeks, sir.
32 weeks, is it?
Fully developed to 34 weeks.
34 weeks. So 32 to 34, but to fully develop it has to be 34. So the baby has to be 34 weeks to develop that Saksallo coordination so that the baby doesn't aspirate. Okay. So any other intervention to increase to make the weight gain better, like already discussed by Dr. Rishikesh, involving the mother.
Involving the mother.
KMC?
Yes,
what is the role of KMC in weight gain?
Maybe bonding will be more, infections will be less, and hospital stay will be decreased. Respiratory efforts will be more vigorous.
About weight gain specifically.
Weight gain.
It will be less or more?
More, sir.
More. So you can try that also. Giving. Suppose the mother wants to feed the baby directly. They're very kind of people, they want to feed the baby. So how will you counsel the mother that the baby is not ready for the feeds? It will take some more time, practically.
We will allow them to give some palliative feeds and
Okay.
tell them that the baby is not able to suck properly and takes time to do it. So it's better to not to give directly from the mother's breast. It will aspirate.
Okay, fine. Suppose you have reached a stage when the baby started breastfeeding. Okay, so you allow the breastfeeding, and the next day you come to the rounds, the sister tells that the baby has lost 10 grams. Then, okay, fine, one day variation. The next day also the baby has lost 10 grams. In 3 days consecutive, the baby has lost 10 grams. So what could have happened?
Despite breastfeeding, sir, we should give measured feedings. So that only breast milk we can't measure, sir.
Right. That is one. The other thing is how much calorie or how much energy the baby is wasting in direct breastfeeding. So babies do tend to gain more weight while on tube and measured feeds rather than directly on breastfeed. So definitely breastfeeding is better, natural way, but there is a transition phase where it happens. Right.
Yes.
Okay. So summarizing the case, so you just summarize in 1 minute.
My baby is a 29-week baby, 29-week 4 days baby, born through elective LSS for indication being oligohydramnios. And baby is now 23 days old and PMA 33 weeks. Baby is in room air, weight being on 10 centile. Gaining weight 2 grams per kg per day.
Gaining weight?
Sir, 20 grams per kg.
20 grams per kg. But you are not happy with that, right? So you are looking for other interventions to increase more weight. Okay, over to Rishikesh.
So if you have to relook at your baby, so what is your final diagnosis? In one word. Your diagnosis is one which is the most commonest diagnosis for any of the growth babies, because that is how your discussion will be built on this baby.
UGR baby.
So that's your diagnosis, isn't it? So this baby is showing you extrauterine growth restriction. And I think at this stage we will stop, because that's the important thing is not to come to a conclusion, but to analyze at every stage your anthropometry, your interpretation of that anthropometry, because that is where your discussion should highlight and look at. And more importantly, beware of all the interventions that you are doing, the contents of all the medicines that you are using routinely for the baby. And so also, if you are doing an ROP screen, you should know what medications you should be using. So I think I will hand over to Dr. Nalini.
Thank you, Rishikesh sir and Arjit sir, both of you. But Rishikesh sir, I liked your discussion for the students, the way you step by step you went completely to failure to grow or the failure to put weight. That all the aspects you discussed so well today, because probably they are going to face the same thing. Not only nutrition, you have all the aspects of morbidities which can bother a growing baby is well addressed today. So that's probably will teach a lot of students are there exam going. They will learn, and tomorrow another 5 days only exam. If they're going not only exam later for evaluation also, but during this examination, it is like every baby, every student will get a baby feeding growing baby. A short case possibly. Probably it will help a lot for them. And just one input will I will say, when you are talking UGR and growth, please note it down. UGR by weight, UGR by head circumference, UGR by length. Please highlight. If I am seeing a baby of UGR by weight for less than 1 kilo, I'm not surprised. World over data says 85% to 90% babies of ELBW, whatever you do, at the end of time, when 36 weeks to 34 weeks, still EUGR only. After 44 weeks to 46 weeks, they may compensate after reaching home, after more nutrition, liberal nutrition. But when the respiratory issue, till 34 weeks, 35 weeks, breathing issues, baby at 36 to 40 weeks, 85% to 90% in the world, all the data says they're UGR only. But their UGR by weight, I'm okay. But UGR by head circumference, I'm a little more worried. So to identify the morbidities, when you're talking, talk UGR by weight, UGR by head circumference, UGR by length. So plot it all three parameters and tell where the concern. All three, I'm a little worried. If only weight, okay, probably this baby when goes to 44 weeks to 46 PMA might compensate. That's my message. You conclude that. And when end up the previous cases when we discussed, same thing will happen. You conclude for today's status of the baby. The examiner might ask you, you completed a clinical round. Please give a plan for today for this baby management, an exit plan till the baby is discharged. And for a feeding growing baby, unlike a respiratory baby, they might ask, are the follow-up, growth and developmental follow-up for the at-risk babies who are less than 1.5, less than 34 weeks, typical babies we get in feeding growing. Those babies, always one component, which won't be covered in Viva, will be covered here. Plan for these babies, long-term development follow-up or growth follow-up till what time you are going to ask, how frequently you are going to ask. Those few questions will be out there. And the counsel the family. We kept it in short case also, long case, 1 minute counseling to the family. May not be direct family member, a simulated nursing staff, a simulated somebody, healthcare provider is standing in front of you. I am father of the baby or mother of the baby. Please tell me prognosis and the course of the baby's action. That will be 1 minute counseling for the family. That will be probably included in all the cases. So be prepared for that. This is a learning session, but this is typically designed for the mock examination scenario for the coming exam in the next 5 days. So be prepared, all of you. Thank all the faculties today, starting from Naveen Jain sir, Naveen Bajaj sir, Dr. Srinivas Murki sir, Dr. Teju Pratap, Dr. Rishikesh Thakur sir, Dr. Arjit Mahapatra sir, and Dr. Dinesh sir also, he joined briefly. So I thank all of faculties, including 3 presenters who are very briefly, but they presented well, all 3 presented well. And that's created a learning scenario for us, for all the trainees. So before concluding, if a message, Rishikesh sir or Arjit sir, you can put message to the exam going students from my side. Best wishes to all the students. Still keep learning, keep practicing. 5 days, sufficient time probably to practice 5 cases, each day 1 case. You will be well prepared for the day of examination. From my side, this much. Again, any final message, sir, Rishikesh sir, to students, because the exam going students, they are going for exam another 5 days.
Sleep well before the exam.
Yeah, just relax and take it any other day and feel that you are in your rounds discussing. That's all. No tension. Just relax. And all 3 presenters today did really excellent. Really excellent. If you just maintain your normal flow, don't feel that it is exam. That's all.
So thank all the 3 organizations. I'm closing the session here, and next Thursday, Noel continuously is going for last 11 sessions. But next Thursday, we have done preponed Monday because Friday onwards the exam starts and it's holiday also. So Thursday, no session. All the trainees, the next session will follow next week on Thursday again, not this week, Thursday. So with that, I'm closing the session today. Thank you all. Bye. Good night.
Thanks. Bye.
Thanks.
Good night.
Thanks. Bye. Thank you. Bye.